morning, ladies and gentlemen. Dr. Greta thinks that I have wisdom, but I think everybody has wisdom. Everybody has something to share. Mine is to welcome you to Mbarara University of Science and Technology. Where we are now, we are in Mbarara University of Science and Technology. One of the things that we as a university is proud of is the opportunity that we give to young people like you here to explore those fuzzy ideas in your brains, explore being guided by your mentors to crystallize them into something meaningful that will contribute to improving health in our community. As you see from the theme of the hackathon this year, is building a resilient healthcare system in the era of emerging pandemics through innovation. One thing that the COVID-19 pandemic has taught us is that you can never be too prepared. But you need to be prepared nonetheless. It has taught us that all along we had the science to do certain things, we never utilized that science. All along we could meet, the whole world can meet in 1 second without having to travel thousands of miles or kilometers to meet. I have just left a meeting, which when I was agreeing to come here, at 7:30 I was called, are you preparing to, ready to give your presentation? I was in the showers and jumping out and drying myself, quickly opening my laptop and beginning to make my presentation in that meeting. In other words, we have had this technology all along, mobile communication technology, all along. But we have always traveled all over the world to go for meetings. Now the number of meetings I attend these days sometimes surprises me, because I realize I am meeting with people from all over the world. The time zones vary. Sometimes you're starting a meeting at 7 p.m. when it is morning for others. Sometimes you're starting at 6 a.m. here when it is evening for others. But nonetheless, you have to continue to do that. In other words, the pandemic made us realize that there is a lot we can do with the technologies that we have. The other thing is, there is a lot of technological innovation that we can engineer, we can craft, and it is there in your brains. It is there in your minds. It is what you see every day. You see a gap, and you say, what can I do to improve the situation I'm in? The best thing you can do in a discovery is for you to recognize that there is a gap. And that's why, under Camtech, we give you the opportunity to explore that gap that you have recognized. And you think what you need to do about that gap. What can you do to address that gap? Otherwise, we would all be consumers of technologies that are already being developed and exploited elsewhere. And that is what has happened in Africa and low-income countries like Uganda. How many of you are using smartphones? How many of you use the magneto telephone? Do you know what is called a magneto telephone? Does anybody remember? How you said yes. How were you able to connect to somebody in Mbarara High School and you are here? using the magnetotelephone. That was even advanced. This one was advanced. What was the original one? Does anybody remember? Yes, you cranking the thing and you put the speaker and the earphone are different. The speaker is here, the earphone is there. You have one piece here, another one here. Hello, operator, give me, I want 2-3 lira. And the operator will tell you, I will call you back. After 6 hours, you are connected to 2-3 lira. That was as late as the 70s, 1970s, in Uganda here. By the time we transitioned to this one, now you can dial on your own in the 80s and so on. And today, you can even dial without touching your phone. You pick your smartphone and say, call Opua, and your phone calls Opua. So that's a transition in communication where we in Africa leapfrogged because the original inventors went through this magneto thing for years. This wireless communication developed from a movie. Yes, movie imagination. It was a what they call it, sci-fi, science fiction movies, where in the 60s James Bond could speak from his wrist and so on. And today, that's what we are doing. We transitioned from that to the mobile phone, where now my grandmother, bless her soul, if she was alive today, she would be using the mobile phone. That's the kind of technological transformation we are talking about. What does it require? It requires we to recognize a gap in the need to do something for the sake of society. We are talking about building a resilient health system in this era. And we are going to do that through innovations. Innovation comes from you and me. We need to think its feasibility. First of all, is it necessary? Is it going to bring any good? Then if you think it is necessary and it is going to bring any good, the next thing, is it possible? Is it feasible for it to be done? That's why you're going to sit, think through this, and you will pitch your ideas. And there will be people to judge, to say, yes, this is okay, the idea is good, but it may not be feasible or possible. The other will say, yeah, this one is good, it can spur development in this country and improve healthcare in our country or in our community. And so that's why you are here today. And my prayer is that you are going to take this opportunity with the support from our funders. This project is being funded by some very kind-hearted people in the US. They call themselves the WIS Medical Foundation. All right? And they have given us money to develop something to improve our lot. Yeah? So it is up to us to make good use of this money. It's not enough for us to sit here, wait for juicy break tea, then wait for a sumptuous lunch, and I hear there's a tale of a cock in heaven. Right? Yes, through my short life, I have noticed 3 types of category of people who attend workshops. There are the flukers who come in because there is something to gain, where maybe you sign off something and you go away with some money. Those ones will be there. They will come and register very nicely, and if there is a sign off, they will sign and then go at the end of the day. There are those who come and sit and they think of when is the health break, when is the lunch break. And then there are those who are coming in to participate and contribute to the purpose for which this workshop or the meeting has been called. I would want you to be the latter group. Work, contribute, Walk out of here, even if your idea has not been selected to advance, you have contributed. You are proud of yourself that at least you brought an idea and people heard about it. Some of the inventions that today we enjoy were scoffed at the beginning when the original thinkers brought them. Right? The Wright brothers, what did they invent? Doesn't? Now I want to look for who is the youngest person here. You look like you're very young. Do you remember these fellows called the Wright brothers? No. The world is nice. Somebody there. Who were the Wright brothers?
The Wright brothers were the inventors of the airplane.
Of the airplane. If you read the story of the invention of the airplane, you'll see how society can laugh off even the best ideas. Because the moment they say, what? You fly? Forget it. You cannot fly. To make a piece of metal fly, no way, you cannot make it. The guys kept on trying, they kept on trying, and the first flight was how many seconds, how many years of it did they fly? Does anybody remember? Go on and read. I think there were 11 seconds or something like that afloat in air. That was the first sign of success. When everybody has brushed them off, say you cannot fly. Nobody can fly. Today, the whole of this building can fly. Yeah. There are stories about the biggest aircraft in the world. I think it was designed by the Russians. Something like that. The biggest aircraft. Tons, tens of tons, which can be made to fly. Today, all of us sitting here sits in the smallest aircraft and we fly. And yet, if you ask me to carry you, you are too heavy for me, right? And yet, all of us can fit in those planes, plus your cargo, plus everything, and zoop, you're up in the air. Meaning, the best ideas may be the least expected. And so don't be worried about what your idea is. Bring it out. That's what we want to hear. Bring out that idea. Bring out that idea of innovation. That is what we want to hear from you. Because you never know whether it is going to be the only one to change the course of history. And what a wonder if it will be, or a pleasure if it will be generated in this room, in this beautiful city, in this country of ours in Uganda, and from you, or by you. So I want to thank Camtech Uganda for organizing this Meditech Hackathon. I want to thank our coordinator of this project, Dr. Stephen Simon, and the other project leads within the First Mile project, who are part and parcel of what we have been making use of this money. I want to encourage you to, even if you fail this time, if you're going to have another hackathon next year, just come back, improve your ideas, and come back. Because they say you keep on trying until you do what? You succeed. Try once. If you fail, go back and reorganize yourself, come back again, and you'll succeed. Life is successful, or life can only succeed in those who never give up. Yeah? Because you can never be sure that it's not going to be you who is going to come up with the brightest or the best idea. Can any one of you here tell me that yours, what you are thinking of, is the best right now? Until it comes out, because we don't know what is cooking in your head. Until you bring it out, and then I will be the first person that you're going to innovate, who can just look at you and make a diagnosis of what I'm suffering from. There was this lady from the US who said, a drop of blood, of course she was calling people. I think you have read the story. A drop of blood, she uses a drop of blood to make all the diagnoses you have in your body. Of course, she was a con woman. But people bought it in the US. They spent billions of money on this lady because he had this super machine which he had developed, which all you need to do is put a drop of blood, and it will tell you whether next year you get cancer or you know, things like that. But I wouldn't want us to go that line. I want us to go through things that can be tested and proven to be right. So I want to thank Dr. Beta for inviting me just to chat with you. I don't think I have wisdom, as you were saying, but I can just tell you that yes, for my part, I am happy to be part of your ideas and waiting to see what is going to come out of this time. As a university, we are happy of the collaboration we have with our partners from the Mass General Hospital, who have been supporting us a lot through our collaboration. I think it is called the Global Health Collaborative, where we have partners from Massachusetts General Hospital, and either they come here or we go there to interact with them. They have a permanent home in Mbarara, and that's true partnership. There are many partnerships where it is in the air, but this is physical, it's real. They are here on the ground. There used to be an American coordinating, now we have a Ugandan coordinating. Meaning, they have been teaching us how to drive, now they have given us the steering wheel and say drive. So if you drive it off the road, Stephen, it will be us who have failed. We cannot now say our partners have failed us from the US. I have to head for Senate meeting right now, and I think I want to end here. Wish you well. I should have spoken after Dr. Edgar Mlogo had given a brief on this, but we have flipped the program to allow me to go to the next meeting. I wish you fruitful deliberation.
Thank you, our Vice Chancellor, for the words of wisdom. It is always a pleasure listening from you. I can guarantee that the three categories of people you mentioned, at least we don't have allowances, so the first category is not here. So we remain with the second and the third category, and he mentioned that the second is for eating. But I know majority of us, 99% of us are in for the last one, which is to be a part of a critical mass that is going to involve innovations. Professor Edgar is supposed to come in to give us opening remarks. Colleagues, I can see the house is full. I think we are waiting for the Vice Chancellor to come in. Welcome once again for those of us who came in when the Vice Chancellor was addressing us. My name is Andrew. I know Misha. I work with the First Mile program, of which Camtech is part. Before Professor Edgar comes in, we want to prepare the teams that are going to be part of the panel, and we'll be starting with the dancing team. Please get ready. I know the whole team is constituted. May I now use this honor to invite Professor Edgar Mlogo, the head of Department for Community Health, to come and address us. There is a representative, friends. Welcome.
This is not Professor Edgar. My name is Dr. Brian Triche. I'm part of the Department of Community Health, and I've been asked to represent Professor Edgar today. Ours is just to welcome you, to thank the partners and the organizers of this function and remind the participants to pay keen interest to the panelist discussions that are going to take place. As already hinted on, we have two panel discussions from the nursing department and from us, the community health department. It is from these panel discussions that we expect the challenges that will be innovated around in the next 2 days to come from. So we therefore hope that this will be a very interactive and very fruitful session. And we hope that the themes that have been chosen will be very important for us to pick our challenges. I thank you so much, and we look forward to the panel discussions. Thank you so much.
Thank you, Brian. Friends, when you look at your program, the first panel, which is panel 1, is going to engage us on care and safety will remain at risk. Unfortunately, the future of nursing is threatened world over. This morning I was reading about statistics from World Health Organization for their report of 2021 that is estimating that we will need by 2030 36 million nurses in practice around the globe. I'm not sure what we have in this country, but I know the panel is going to tell us that. But that also requires that we need to enhance many things in our training. We all know from everywhere, most people say nurses are rude. But I am not very sure whether anybody bothers to know why. Maybe because they are stressed. Maybe because they walk around like crazy in the whole hospital. I know in the football field, these people have had the technology of calculating the distance covered in one football match of 90 minutes. And they can able to tell you that within those 90 minutes, a certain good player has run for 16 kilometers. I don't know how many these nurses cover in a day. I don't know whether anybody bothers. I think it's appropriate that now that we have them at the center of this stage, we together try to innovate things that can help them reduce on their workload, but also reduce their stress if they are going to be effective. So the panel that is led by Dr. Grace, I will invite you to come and take your seats, and then you take it on from there. Thank you very much. You will notice that this panel is multidisciplinary. We have colleagues who are coming from the education sector. We have others who are representing community, but we also have others who are in practice. So it's an interesting opportunity. We look forward to getting a lot from you. We continue to welcome everyone who has come from far and near. Welcome. You have not missed anything. The first panel is just started.
God bless.
Good morning, everyone. You are most welcome to this pre-hackathon summit. And as the first panelist, we are really excited to have you around. And I'm going to introduce to you quickly the panelists we have today. On my immediate left, we have Emmanuel. Emmanuel is presenting the clinical setting. He's coming from the hospital. Next, we have Valence Nyozma. Valence is coming from nursing department, but also with clinical background in critical care. Next is Florence Esther Berwa from nursing department education, but also with clinical background in surgical nursing. Next, we have Esme with the background of community nursing. So you are most welcome. We have a rich presentation, which is multi-dynamic. Our theme of this morning, we are looking at the re-imaging nursing education, practice, and community involvement in the era of pandemic, emerging pandemic. Globally, we are aware that education practice of students is disrupted, and yet, according to UNDP 2020, it is that we should be able to be prepared whenever there is an emerging challenges like pandemics. We should be prepared. We should be able to respond. And when we respond, we should be able to cope. And when we cope, we should be able to recover. And because of that, today's panelists are here to take us through what are those areas, or what is their experience of what has happened in nursing education, practice, and community. We are going to start with education, and my first question goes to Vanessa. How has nursing education been prepared to mitigate these pandemics, to enable them? Remember, we are using the UNDP slogan, prepare, recover, cope, and so forth. So, Valence, please.
Thank you, Dr. Grace. Now, nursing education in the era of pandemics has had a number of challenges, and to that effect, the training has not adequately met what is expected. As all of you are aware, Mbarara University is currently, under the Faculty of Medicine, is currently implementing a competence-based curriculum where the trainees are supposed to spend approximately 50% of their time in the clinical setting and also 50% in the theory, so that there is a good mix between the knowledge they acquire and the skills that they get within the hospital. But in the era of these pandemics, you will bear witness that during the COVID-19 pandemic, this was not possible. This was not possible where our trainees would not get the 50% of the time that they are. What came on as an innovation to bridge that gap was then that simulation came on board, but the feel that trainees get when they interact with the patients is not the same that they get when they are dealing with models to see how particular procedures should be done. Secondly, is that even when there was a shift from eventually we saw that the required competencies were not met. The required competencies were not met because of the disruption in the way the curriculum had been prepared vis-a-vis the way it was implemented during that pandemic. But also we note that generally the nursing education institutions were not prepared to handle these pandemics, just like any other institutions. People were not ready, and so when these pandemics hit, people were operating in the flight mode. This has happened, so what next do we do? Instead of being proactive so that they plan for these pandemics before they occur, we saw a few things being done once the pandemics were already with us here. All of you have heard about the Ebola hemorrhagic fever, which is in our neighborhood here. But if you go back to our institutions, there is nothing much that has been done to make sure that people are prepared to handle these pandemics and to make sure that they know what should be done in case that they get these victims who already have the disease. And with all of this, we see that, as we see that the level of preparedness is low, the mitigation strategies within institutions are lacking. Eventually, the coping takes a longer time, and that's why we eventually live with the effects of COVID for quite some time. That's what I can say for now. Thank you.
Thank you so much, Vanessa. You've taken us through how the mitigation and the preparedness by institutions should be so that we are not thrown into panic. We should be prepared. But you've also shared the experiences of nursing students to cover 50% in clinical and 50% in theory. And during pandemics, these were also affected. I would like us to talk about how about the human resource? Because when we talk about mitigation and pandemics, there are issues concerning human resource. I request Esther Bewa to take us through that.
Thank you so much, Dr. Grace and Valence. Regarding human resource, this is something that has affected clinical setting, has affected the education setting, all that. So, when there is shortage of mentors and supervisors, yeah, it affects both the learner and also the teachers who are teaching and also the staff who are carrying out healthcare provision. So human resource, it is very, very important in the clinical area and also in education and also the materials. Because being in a pandemic, we don't expect the learners, also the people who are taking the learners, to do a lot without these materials and human resources. Because these are very, very important. And without those, there's nothing much can be done. Thank you.
Thank you so much, Esther. We know that human resource plays a key role, but during pandemic, we were told only a certain percentage should be on duty and certain percentage to be at home. And in education sector, where nurses are supposed to have 1 in 5, according to WHO, in clinical setting. And if you have only 2 people on duty and then some are to remain at home, that is a challenge. So we see that as affecting the students' learning. But also, we realize that in the era of pandemic, we have this new technology. How are the nursing education prepared, or how is the department prepared to mitigate in terms of this technology? I remember we had to quickly introduce the students to Zoom, to e-learning, and so forth. How were the staff and the students and availability of all these resources handled? Valence, please.
Thank you. Now, with the use of technology, I had already highlighted that the infrastructure was lacking. But in terms of preparation, I remember the members of staff underwent some bit of training. But I should say it was not sufficient given given the demands and outputs that were required from these members of the staff. I am not sure whether there was any training for the students so that they are able to use the e-learning platforms. That I need to be reminded. But for the members of the staff, there was a bit of training, which was not sufficient, I should say. In terms of the infrastructure, all of you agree with me that for it to embrace e-learning, you should have a stable internet connection. You should have some other tools to use, computers and the like, and quite often are not in place. Even when they are not in place, they are not sufficient to help people adequately implement e-learning.
Thank you to Adon Mbarara. This was introduced and it was a new experience for both the learners and the students. And on top of being a new experience, it was so the learners didn't take it in a good way because it was too much for them and it came abruptly. So that's why it is very, very important all the time to be prepared so that in case something comes up, we are always prepared for such. Thank you.
Thank you so much, Vanessa and Esther, for that clarification regarding the technology during pandemic. But also we want to emphasize that the curricula itself should not wait for pandemics. There should be something embedded within the curricula of nursing education so that it is reflected in the implementation of challenges like pandemics when they occur. At this juncture, we would like also now to move to the practice, because we said education and practice goes hand in hand. But we are aware that in practice, with the emergence of new pandemics, some of these conditions do occur and take us by surprise. Oftentimes, some pandemics, we read them. For example, I remember when Ebola first struck, all we knew was there was a kind of disease called hemorrhagic fever, but no one had ever gone into detail to understand what are these kind of diseases, apart from lumping them together. So we realized that the knowledge, what was taught yesterday, may not be the same by the time you go to the clinical setting. And I would like Emma to tell us more about knowledge obsolete in clinical setting in relation to pandemics. Thank you.
Thank you very much for the opportunity granted to me. My name is Tegeki Emmanuel. I'm a nursing officer. I work with First Mile. In the era of pandemics, quite often we are caught unaware, especially these new emerging pandemics. And when they come to the hospital, of course, sometimes there is low suspicion index among the clinicians, and we get these outbreaks. And you find in most cases, the healthcare providers have little or limited knowledge about these pandemics. And as such a challenge, it happened in COVID. People didn't know much about COVID-19, especially the healthcare providers. Most of them were caught unaware. And a lot was done to train. And really, to me, as we practice in our clinical settings, it should become a culture that once in a while we get CMEs about these rare pandemics that come occasionally, so that when they come, we are aware of what to do. Because knowledge may take long to spread to the entire healthcare providers in the healthcare system. So that is the main issue. I think we need to find innovations around sharing this vital information regarding these rare and occasional pandemics, so that we are well prepared and we have adequate information to handle such pandemics. Thank you very much. Back to you.
Thank you so much, Emma. Emma has mentioned that in clinical setting too, they were taken by surprise, and the training that occur when there is already fear in people, I don't think it is really internalized and people really appreciate. I want to give an example during Ebola pandemic, the first time. Even healthcare workers would not wait to receive. People were running off. I remember once in our main hospital, a patient was on he wasn't a patient at that time, but a man vomited blood. No, he had epistaxis on the bus. And everybody jumped through the windows and left the driver with the other man. The conductor said, "I'm taking the money, you'll also find me there." So the driver wondered whether he should also get out of the bus. So he told the man, but because he was presented with similar situation, like of Ebola. So the man drove the bus, critically making sure the man didn't move nearer him. Now, outpatient was full. The moment the man entered with the big bus in the regional referral, participants, I can assure you, everybody got better. People disappeared in a minute. The only patients that remained were those on traction. So, healthcare workers also took off, survival for the fittest. So this training of people when already an outbreak has occurred probably has limited impact on making people to appreciate how you can contain the situation. And internalization of that knowledge can be minimal. And that's when we get errors among healthcare workers. We tend to get errors because you've been taken through before you go into the treatment center, maybe of COVID or Ebola, but because you've just been given that knowledge there and then, I believe we are going to find innovation around this area so that our healthcare professionals are well prepared in advance so that we don't give them information at the when an outbreak comes. So we have had challenges of limited or few nurses in the hospitals. And this has been always a challenge that few nurses taking care of many patients. And this is where mistakes come in. I would like Esther to take us through this discussion. Thank you.
Thank you so much. As we have already said and seen that we are nurses and we are always on the front line. And we are also human beings as nurses. Definitely when there is something that is like a threat or a pandemic, we all die, and so we have to make sure we preserve our lives. So once there is this shortage, and you expect a nurse, the ratio, as we have said, it is 1 to 5. That is the standard ratio. 1 nurse per 5 patients. But you find 1 nurse managing about 60 patients. And how do you expect somebody like that one to behave nicely? That's why they always say nurses are rude, nurses are like that. But the nurses are not rude, but they are stressed, and sometimes they get tired because they are human beings. So these nurses, when they are in the hospital, they always need support from other people. And that's why when the students are there, when it is the knowledge, they have to have that knowledge, but still, you have the knowledge, but you have the fear. So they came and asked us, and then we said, okay, you have to go and assist because you are a nurse and you are called to serve. So they went, but you can imagine the way they went, they were not, because they were not ready and they had that fear. And how do you expect someone like that one to nurse a patient? So that's why it is very, very important all the time to be prepared with items. Because by that time, I think the team which was supposed to maybe to purchase items were just starting. And how did they expect the nurses to work without items? So nurses are always there, but still they have to be helped and to be protected. Otherwise, when we are involved maybe in planning, and we know that we need this and that, because the needs of the nurses, we are the ones who know these needs. So when they are involved in the policy making and the organizing and buying these things, I think they could do their best. Thank you.
Thank you so much, Esther, for elaborating how student nurses were scared of going to the wards during pandemic. But also we realized that the healthcare system is composed of 80% nurses. And to build a resilient healthcare system, this bigger number must have a say in how these pandemics can be handled or how we can be prepared. I want Valence to take us through whether the nurses' voices are involved in building a resilient healthcare system. Thank you.
Thank you, Dr. Grace. So it is true that our healthcare system is majorly composed of the nurses, and at the different stages where policies are formulated, there is under-representation of the nurses. We will take an example. In the Ministry of Health, there are probably less than 10 nurses. There is a commissioner, there is a position for a senior nursing officer. There are so many positions that are occupied by our counterparts. When you look at the cities, the current cities that have been created, each city has a position for a city medical officer who oversees health care in the city, but there is no provision for a nurse to oversee nursing care in the same area. So how nurses are represented, yet they don't participate in policy formulation? So I don't know whether there is an innovator who should really come up with something to help us improve the of nurses at the different steps where our policies are formulated, but there is under representation, and yet we constitute a bigger percentage of the workforce. Stemming from the limited outputs in terms of research coming from nurses, focusing on the critical aspects that affect nursing. So again, because of the limited research outputs, there is a poor understanding of what affects nursing care, and so I wish to suggest that the innovators can also look at different ways in which research involvement can be stimulated among the nurses, so that the world out there can have a better understanding of the issues affecting nursing, and probably that will improve their welfare in the healthcare system. Thank you.
Thank you so much, Valence, for what you told us about involvement of research, how research can improve the policy formulation where all the stakeholders are involved. At this juncture, allow me to move to community engagement. We are aware that education, practice, and community are inseparable because the community are the end users of the services offered by nurses. That in the era of pandemics, community involvement is limited, and oftentimes when a pandemic occurs, we tend to move away from the community. We fear them, and because of that fear, we tend to develop a blame game. And when we develop a blame game, community in response decides to keep it to themselves until it escalates. I want us to recall the presidential speech on Wednesday, when he said he was told that a similar kind of disease happened in August. That's when they started noting people dying. Why was that not being brought forward? Where was the problem? Why did we now wake up when the person came to hospital? So where is the problem? So at this juncture, allow me to request the community nurse, Justus Kwezi, to share with us where.
Thank you so much, Dr. Grace. Called Queen Justice. Registered nurse working with First Mile as a community nurse. Well, from the community perspective, we know that community nursing is the care that is delivered outside the hospital setting, for example, in the home. So, community engagement has been a challenge in the pandemic that in the situation. Two, they are not sensitized by the lack of staffing and the time, especially in planning the strategies that can help to improve and control the pandemic outbreak. Three, most of the community members, most of them they lack knowledge and they are not aware of the pandemic and would like most of the innovators to come across some strategies that will help the community members to get involved in the outbreak. Thank you so much.
Thank you, Justus, for taking us through the community challenges and experiences so that we can come out clearly and empower the community to quickly respond when there is a pandemic. What I mean here is that if you blame me, I'm eating bats, monkeys. To be very honest, if it has occurred in my home and I've not eaten any of those mentioned things, I will fear stigma. And because there will be stigma that it is in my family that we eat, monkeys. Probably somebody could have picked it from somewhere. So I'm likely to keep quiet. So I want one of the panelists to tell us, Valence, how can we overcome this blame game and we all be inclusive and build a resilient healthcare system where we shall all be responsible for the health and mitigate it according to the UNDP policy. Thank you.
Yeah, thank you. I am not very sure whether I have an answer on how the blame game should be overcome. Probably that is what the innovators should focus on. But all of us understand when the COVID vaccine was introduced, because people looked at COVID as a weapon for mass destruction. So many other people had different thoughts about the vaccine, and so it took time for people to actually accept the vaccine, including health workers who were administering this vaccine to a few who had accepted, but themselves had refused to take it up because they thought maybe they are talking of chips implanted within the vaccine and all sorts of things. So it takes a lot of concerted efforts for us to change this blame game, where we associate diseases to particular events. For example, people say Ebola could have started when people ate monkeys, and so it requires a change of perception in the way these diseases arise, so that when any member of the community eventually has the disease, then they don't feel out of place and they find it easy to walk to the facility and say, I have this problem, please help me out. Otherwise, if people still think that when they go to a health facility presenting with the symptoms of the given disease, and then they are blamed, they will stay home, and before you know it, the entire community will be affected.
To add on what he's saying, I think also community needs to have a communication structure. If you know that maybe somebody in a certain home has a challenge or a problem, then you know that I'm going out maybe to LC1 and report. Then that LC1 person will be the one responsible to go to report. Otherwise, people are going to fear because they know once you report, then they are going to blame you as my colleagues have said. So there should be a communication structure, and then that one is going to assist in passing this information without any worry. Thank you.
Thank you so much for your contribution, Vanessa and Esther. We are also aware that during pandemics, people have the knowledge, but this knowledge never translates into practice. We are hoping that the innovators will help us in this area. At this juncture, I would like to say thank you to the panelists, but now I would like to invite the participants for your contribution in either nursing education, practice, and community engagement. Thank you.
Thank you so much. I've been practicing as a biomedical engineer for now 3 years. But when the pandemic came, I made some observation that there was a shift from hospital care to home care. People began buying oxygen concentrators, take to their homes, oxygen cylinders, take to their homes. And I doubt these homes have nurses. And you know, oxygen is a drug. So I don't know how they're doing it from their homes without a nurse. Nobody will go to the pharmacy and buy Panadol, they tell you 2 times 3. So who was doing it for the oxygen? This person was having problems with breathing. So in that area that was neglected when we went to shift to home care. Then the other element I observed was, I've seen nurses moving beyond to do immunization into different villages. So is it possible to have mobile nursing that can move from home to home, checking on people who are sick and afraid of coming to the hospital? And how can we help these people who are afraid of coming to the hospital but are sick in their homes? Then we talked about something about 1 in 5. 1 in every 5 patients. Is there not a way we can help a nurse monitor so many when she's only one in a hospital? Innovators in the house who can think of best methods of helping these nurses monitor so many who need their care, but remotely. Then the other thing I want to share with us about is about community empowerment. What do you, which plant do you put? And it is passed on from us like that to next generation, another generation. How best can we pass on the nursing skills into our communities? That when we get the nurse from our village, the whole village benefits from this nurse was going to school. Most times we study things in a foreign language and cannot be given another language in our own setting. What's the name for Panadol in your Nyankol? Which is equal to Panadol. So when it comes to translating the language we studied at school into the community. Isn't that a problem with nurses who are unable to speak Nyankole or Mword and need a translator to translate for them? Innovators in the house, can you help us find means of how best can we quicken the service of these nurses who are sacrificing every day to our people? Thank you.
Thank you so much for that contribution. Person?
Thank you so much. I'm Ian Ricky from Dorita. I'm a clinician and I specialize in Meditech. I'd like to talk about community health and education. When it comes to community health, I think there is a very big gap when it comes to community health in that the community lacks access to information. Empower the communities with information, decision making is fast and access to services is also faster. For example, you find that someone has had fever for 3 days, but we always tell you that I have malaria. But we all know that fever is a constitutional symptom. So if we could avoid information to the community, it will be easier for patients to access services, that is drugs and any other thing. Education, most of the central hospitals, let's say the referral districts, they have Wi-Fi's. And I know specifically in a week they have some CMEs. On Doctor, we've created this platform whereby you're going to be having CMEs 24/7 on your phones and health tips. You read offline and online, whether you have data or not. You can access information, read as a nurse, and at the same time the patient can read the same information. Yes, thank you so much.
Thank you for the contribution. Then behind.
Thank you very much, moderator and the panel, for the very interesting information you've given us. My name is James Wafula. I come from a totally different background. I'm not into the medical or the nursing. I am a diplomat and I am in that area. So in this, I'm going to just give my observations as a layman, not a professional. Nursing education, from what we have heard, the practice and the community and the education. I want just to give an example when we address the issue of the blame game. Where is the blame? And I want us to focus. Sometimes everybody blames the nurse, but actually the problem is elsewhere. Because the nurse, when in an epidemic, the nurse is also a victim. So much as the community is expecting the service from the nurse, but the nurse is also a victim of the same epidemic. So a lot of times we put the nurse on the other end, yet he or she is actually on our side. But then when we start to address where the blame game is, the nurse plays their bit. But I want us to look at two levels: the community and the leadership or the policy level. I'll give 3 examples. We had the COVID epidemic recently. It was a general epidemic around the world. But I want to give you the examples of, say, Uganda, we had Tanzania, and the US. All these were faced with the same epidemic. But the issue of leadership and the policy. In Uganda, we needed a team of scientists, lockdowns, and so forth to deal with this epidemic. In Tanzania, the president who was there then said there's no epidemic, just close our eyes and our ears. So, and then in the US, you had the president who was Trump saying this is not a problem. So the nurse in each of these environments is faced with an epidemic, but their chances of action or whatever they have to do is determined by the leadership and the policy. So where do we look at it? So when we look at the blame game, I think let's focus more on policymakers and leadership, because that's where decisions will be made. And if a decision is made, if the policymakers and the leadership are positive, then they'll address the challenges like lack of motivation in the nursing resources, providing human resources and financial resources, providing equipment and promoting innovation. So if the leadership and the policy level, leadership at the policy level is not on point, the nurses found a very difficult situation. So that was my contribution if we are looking at where to address the solution. Policy and leadership, it makes a very difference. And a very big difference. Thank you very much.
Thank you so much. Behind there, Christine.
Thank you for the opportunity. My name is Christina Chiu. I'm a lecturer and acting head Department of Nursing, Faculty of Nursing and Midwifery, Lira University. And at Lira University, we have a unique system. We have our own owned hospital, the first of its kind in the country, where the lecturers manage the hospital. The challenge that I have observed is that, like already the panelists said, when you have shortage of nurses, like you have one nurse on the ward or two, the issue, apart from having the low number of nurses, you have nurses working very long hours. Our shift is 12 hours. So by the time they finish the 12 hours, they are actually exhausted, there is burnout. And one of the issues that come up is that the update of patient register, because when patients are admitted, patients should be discharged. And yet you find we use manual system to do that. But if we had an electronic system to manage patient register, admission and discharges, I believe that would create a difference. Two, the nurses need to always write a report and hand over the report physically. And if we had a system in place, health management information system in place that is more of electronic, that these issues are captured electronically other than physically, that would also create a difference. Because nurses do a lot of work, but you can hardly see the work because of the system that is used for documentation. Thirdly, when nurses move on shift, they are supposed to have inventory record updated and handed over to the next shift, and also stock record updated, stock for drugs updated and handed over. And all this is done manually. So if we could have an electronic system in place, I believe that would create a difference. Then going to the issue of pandemic, our patients come back with the medical form files or books from whichever place they come with. And some of these documents are actually contaminated, but our nurses are exposed always to this. They have to receive, not only nurses, even the doctors. So if we could have another system in place of keeping this information so that it doesn't matter where the patient is seen from, if they're seen from a health center or from a clinic, that information could be quickly retrieved from another system. I thank you all for listening.
Thank you so much, Christine. Yes, please.
Yes, Chris. My name is Rupata Godfrey, a student at UMass. And the few points I noted, first and foremost, one of the panelists identified that there is need for a communication structure to report the outbreaks and also to make the information flow. For example, she used reporting to the LC, then the LC giving this information to the people responsible. And in so doing, I would really kindly submit that if there are fringe benefits put in place, it can encourage these people to actually give the reports in time, and also we avoid a blame game, such that if someone knows that you have reported in time, he or she can be given something or a prize for fostering or for reporting that incident in time. It can encourage massive reporting and communication. Then the nurses also face the problem of us, the community, where there is self-treatment and delays seek medical services. You find that you are at home, you wake up, you are not feeling okay, but all of a sudden you go to the nearest clinic or drug shop, you buy the so-called Panadol. You do the self-treatment instead of going to the professional facilities and seek the right medication. I think self-treatment is also still a big challenge. Then finally, we talked about uh, failure to have the outreaches to the communities or the people who are there in villages and they are sick. I would kindly suggest that maybe an app can be developed such that if you really in need of a medical service in your home, you can easily tap and locate where you are. Then it can be you can actually be helped here and there. Lastly, we can also encourage or foster health center collaborations with the communities. We have gotten the health center 1, 2, and 3, but people no longer use these health centers. They rush to regional referral hospitals. So we can put in maybe more sensitization or collaborations with these health centers, and we actually put there the necessary drugs and equipment such that people, when they get there, they are not really biased to move to other regional hospitals. Thanks very much.
Thank you so much, the participants. We are running out of time at this juncture. If you have any other suggestion, I think we can share it later on. But at this moment, hey, you see this thing blocked me. Sorry about that one, only one, please. You know, I didn't see this side. Sorry about that. Yeah, it blocked me. I was focusing.
Okay, thank you. Basim Majo. I'm a psychiatric clinic officer working with Empower Through Health Uganda. And our area of operation is Biende district. But I've had an experience of working in different parts of the country. So there are several challenges I've identified in our health sector, including language barrier, especially where health workers are not able to communicate effectively with the patients. But I've thought of several solutions that we can have. Maybe we can have like all of them in one application. One is we can have, okay, from the health facilities I've so far worked in, whenever I travel, I map those facilities. I'm a Google Guide level 7, so I do mapping for these health facilities, and I feel like that can also help in like delivery of medicines. If we can use, for example, drones to deliver medicines in time, then I also thought we can also have like a better health information management system where like we have an online platform where all these records can be uploaded from these health facilities using maybe tablets or smartphones instead of having to wait for like the government to intervene when we don't even have data to present our problems at the health facilities. Yeah. Then I'm also in collaboration with some Ugandan in South Africa. We do statistics, like major statistics work. Currently, we've been working on football, but I think we can also do something in the health sector such that we are able to know the number of patients who have malaria in a day, like from all facilities in Uganda. We can have like all those statistics for each condition uploaded on a daily basis, and we can have all these records. Then that can help us in planning, like for how much medicine do we need in this facility, what do we need to do in case there is a new condition that has been identified in a certain hospital in Arua, and maybe the medics have not been able to know which condition it is. It can be reported there and then something is done about it. Thank you.
Only one on this. Okay.
Thank you so much. My name is Dr. Mbarara. I work in Mbarara, that is Chinonera Center for the lower facility. I was looking at maybe improving the, Uganda now we have the high maternal mortality rates. We are around the now 343 per 100,000 births. And these ones can come mainly from, as we say, majority of these mothers are cared by the midwives and the nurses. But I was looking at the pantograph. We still have a big challenge monitoring these mothers, and it's not only the lower facilities, but also in the hospitals. So I think there is a challenge, since we are still using the hard copy, the paperwork of the pantograph. If there was a way of modifying the pantograph such that it is electronic, then we look at those indicators. Maybe just click, when you're monitoring a mother contraction, just click, maybe a photograph, maybe we just click, just that we reduce on those incidences. That area. Also, it can help so much. Thank you so much.
Thank you so much, participants, for your contribution. At this juncture, I will give each panelist just a 40 minutes for your final say in what we discussed so that the innovators can pick the message. Thank you. 40 minutes, please.
Thank you very much. One most important thing that the innovators you need to think about is how can we do virtual monitoring of vital signs among patients. I think that can be a great achievement in lessening the work of nurses, given the very high nurse-patient ratio. Then the other important thing, the innovators, you can think about how can we improve on early diagnosis and having the appropriate clinician for a particular diagnosis. Thank you very much. Those are my words. Allow me to move to the next one.
My main area of focus is how do we improve the quality of nursing care amidst the shortages of nursing that we see in all the healthcare facilities. If this area is addressed very well, the maternal mortality that our colleague has mentioned will reduce, and generally the outcomes of most of our patients will be better. Thank you.
Thank you. Also, if innovators could look for a system whereby nurses are motivated and they work under, without stress, by improving maybe on the system where more than when one nurse can look for, can care for patients more than 5, so that they work without stress and without worrying. And also, another thing, the structure, which I also talked about, the communication, how innovators can also improve on the communication system for the community members so that they also get that chance. Thank you.
Thank you so much. My main concern is about the communication strategy, especially in the community. My request is about how shall we improve on the communication team to reduce on the outbreaks. So this goes to the innovators, the mode of communication, the system we can evolve, so that we can improve on the communication within the community. Thank you so much.
Thank you so much, the panelists, and at this juncture, I would like to thank them so much and thank the participants for your contribution. And I believe in Ubuntu spirit, we are all going to collectively find a solution that can enable us to build a resilient healthcare system through re-imaging, nursing education, practice and education. And I wish everyone good deliberation today. Thank you so much.
Shall we clap for this panel? Thank you, Dr. Grace and the team. I know everybody has had their own take, which is very important for starting to form the ideas and the innovations that we want to see in the next few years. Thank you very much once again. It's a full house. If you are in front, try to see behind and see what is there. You can see the importance of this event. If you miss today, you most likely will not have an innovation that will respond to the theme for this year's hackathon. So that's why this is very, very important. I want to recognize a few people who came in. We want to recognize especially the Chancellor, Embassy of Uganda in Burundi, Mr. Wafula James. We want to recognize the Rector, University of Ngozi in Burundi, and your delegation. The Rector, those of us who are used to our language here, is an equivalent of the Vice Chancellor. So he's a very important person for us. I also want to note that, by the way, this is not his first time coming and his team. We have forged a very strong partnership, especially with Camtech, representing Mbarara University. I understand our Camtech team has already been invited several times to join in. We want to recognize that partnership. We also want to recognize Christine, our very own, from Lila University. Did you come in the delegation?
I came alone.
Thank you for coming home. I know you have been part of us for a long time. It's always good to come home. Colleagues, I know we're all listening in, but re-imaging the nursing profession, I think many things have emerged. For me, these are like take-home messages as we go for our break. First of all, in terms of teaching, I think what is emerging there is that there are knowledge gaps plus equipment and infrastructure. So I don't know what innovators are thinking around that, because we also know that even in practice, I think they are emphasizing the issue of knowledge, because new issues are emerging. And I know community health is here, and we are running continuing medical education everywhere. Why don't we start with our own, since we already realize in the house that there are knowledge gaps? Instead of moving out to the community, why don't we first empower our own? I think that's very, very important. And I also heard someone here that they are having continuous medical education thrown on phones of health workers, and you can access that even when you don't have data. Is that right? I think that's a good area. The third thing I think I am listening into is that there are issues of leadership and policy. I'm not very sure which innovations can come there, but I think they are important things. I also learned that lecturers in the Lira University are the ones who are managing the hospital. But what is true is that whatever innovations that are going to emerge, we must make sure that we make our nurses happy. We must make sure that they are less stressed. Because if they are less stressed, then they are going to pay the attention that is required to our patients, and then that is appropriate medical care. Of course, what that means is that innovations around nursing must come in areas that are going to allow us to reduce the workload of nurses. And I heard from the discussions from the audience that issues to do with registration, with inventory and stock taking are areas that this house can innovate around. Thank you very much once again. Of course, our Vice Chancellor, before he left, he said, as we think about these innovations, be sure that your innovation is feasible and that it is affordable. Feasible and affordable. Our breakfast is ready. I will request the team led by Collins and Mary and everybody. You want to stand and people see you? We are going to have our breakfast. It is just in the corner where I was just starting from. I will request for purposes of courtesy, we allow our visitors, especially from Burundi, to have breakfast first. But please, we have exactly 20 minutes to have our breakfast, and then we come back. You don't want to miss the next session, because the next session is going to be led by community health. And it is something to do with universal health coverage. Thank you very much for now, and let's go for the break of 20 minutes.
Thank you very much. Before the second time.
agreed that for those who have not finished taking their tea, it will be a working tea for you. And the beauty is that once we resume, the first few minutes are taken on by the panel. So that will not stop you from continuing to take your bite. And I'm sure by the time they finish, we will have finished our tea. Now friends, panel 2 is going to discuss a topic, a central topic of accelerating progress towards universal health coverage in Uganda. What can we do better? What can we do better? I wanted to mention a few things. That health is a universal fundamental human right. And universal health coverage is key to achieving this right. So you can see how important this panel is for us. I also wanted to mention that when we talk about universal health coverage, we are talking about basically two things: quality health care and affordable health care. And interestingly, this is not a discussion that is starting today. It is enshrined already in Sustainable Development Goals, specifically Goal 3.8. But it is also enshrined in issues to do with poverty, because we all know that when the population is sick, it cannot work. If it cannot work, then it will remain poor. And we also know that health constitutes a bigger part of the financial burden for most families. Those of us who have elderly parents, you know that as you work, anytime your mother or your father will break down, and the first call will be for you to have an ambulance to go and pick them, and the costs that are associated with that. Now we also know that we have registered some significant success, and then COVID struck. And so Brian, sharing this panel, I want to give it to you to start the discussion. Thank you very much.
Thank you so much, Dr. Andrew. It's my singular honor to moderate this panel discussion. Once again, the theme is accelerating progress towards universal health coverage, commonly called UHC, in the Ugandan context, and we are looking at what we can do better. As Andrew has already said, ladies and gentlemen, globally there has been an increased call towards achieving universal health coverage. This increased interest in the need was driven by the post-2015 development agenda, the global development agenda, established under the Sustainable Development Goals, which was a continuation of the Millennium Development Goals for some of those unfinished objectives, among them being universal health coverage. As already stated by Dr. Andrew, this is Sustainable Development Goal 3 and specifically Target 3.8 that spells out the need to achieve universal health coverage, including protection from financial risk, access to quality health services, and quality and affordable essential medicines and vaccines for all. Please mark the word for all. In the Ugandan context, universal health coverage could mean that all persons in Uganda have equitable access to comprehensive quality health and related services without financial constraints, all delivered through a multi-sectoral approach. these individuals and communities can access quality, affordable medical services irrespective of who they are, irrespective of where they come from, of where they live. Uganda's movement towards universal health coverage must recognize its current disease burden and other health system challenges. And we have noted that preventable health issues have continued to rise and make up over 75% of the disease burden in Uganda. This disease burden is often linked to other multi-sectoral issues, like Dr. Andrew had said. It's not just about health, this is a multi-sectoral issue. Some of these issues are often referred to as the social determinants of health. Therefore, calling for efforts beyond the health sector to ensure the welfare of the population and the realization of the goal of universal health coverage. Ladies and gentlemen, although Uganda has made strides towards universal health coverage, progress in a number of instances has been low. And this disruption was worsened by the pandemic of COVID-19 and other emerging pandemics that we've seen, monkeypox and of late, Ebola. The population growth has not been matched with expansion and investments in the health system. We still face several challenges that hinder the country from addressing the rapidly expanding health needs. The investments in our health infrastructure, human resource for health, and health financing are still wanting. Yet, achieving universal health coverage is very key in achieving the sustainable development goals. And I'm grateful that Camtech has given us this opportunity because, colleagues, ladies and gentlemen, we cannot continue business as usual. I have a team of able panelists from the lower health facilities who represent the communities that feed into their health facilities. And on my immediate left is Dr. Mutahunga Birungi, who is the Executive Director for Bwindi Community Hospital, right from the hills and the valleys of Kigezi. You're very welcome, Doctor. Yes, next to him is Dr. Ronald Mugali, Dr. Ronald Atwelembire, who is representing the medical superintendent for Rushden Hospital. You're very welcome, Ronald. Next to him is Dr. Mujuni Ivan, the medical superintendent for Rukunyu Hospital, right from Kamwenge district. And next to him is Dr. Atulinda Collins, the in charge of Kabyanda Health Center 4 in Isinjiro district. You're very welcome, Dr. Collins. And last but not least is Dr. Rashid Mugabe, the in charge for Chinoni Health Center 4. And I want to get the ball rolling and just key guiding questions to our panelists who will have maybe 7 minutes to kind of give us their personal experiences, their lived experiences as community members and health facility in charges towards this theme in your respective jurisdictions, colleagues of the health system. Are we making significant progress towards the universal health coverage? Please give us some of these examples of why we are or we are not making significant progress towards this. And what are some of the bottlenecks and challenges towards acceleration to the progress of universal health coverage? Over to you, Doctor. Thank you.
Thank you so much. As I have heard Dr. Roger Mutahunga, former executive director of the time I moved on as now district health officer Kamungu. So to share briefly about our community insurance scheme, E-Quality Health Bwindi, that was started in 2010. The scheme had a relatively higher penetration rate of about 35% within our catchment area. In other words, about that proportion of the population is insured. But it has stagnated around there for the last 8 years or so. And we have had interaction with several other community health insurance schemes, including drafting a position paper to Parliament to inform the National Health Insurance Scheme, that community health insurance schemes should be part of the National Health Insurance Scheme in addition to the social insurance that was proposed for those who are on payroll. But we are arguing that community health insurance schemes would benefit most those who are in the informal sector. That said, the challenges have remained. Notably, across community insurance schemes, the processes and the formulation of these schemes is different. For instance, in Windy, we leverage the naturally existing social networks. Here we have the various society groups which were formed at the peak of the pandemic of HIV to manage death. And when ARVs came around and people were living longer and without so many of these medical complications, the issue was now how will these groups remain relevant. But we argued and said instead of waiting for someone to die and you bury them, let's put resources together and send people to hospital in time and improve health seeking behavior. And we did manage to some extent because now these were already existing groups. There was less, invested in trying to get these groups together because they're already there. They have their own administrative structures. But the enrollment in the equality health insurance scheme has stagnated. Some of the challenges have been affordable premiums. Because you find there are those considered the poorest of the poor. Those that maybe the inverse care law defines best, not had, not seen, and yet they are the most in need of health services. So even if you say maybe for a year you are going to pay 10,000, someone cannot afford that. And I think those are the ones we are categorizing as indigents in the proposed National Health Insurance Scheme. How do we cater for those? And as you know, those, at the lowest end of the spectrum of income are again the people who fall sick most. You find again, these are the very people who have big families. So it's a vicious cycle. That has been one of the challenges. How do we even cater for those ones? The issue of distance. People still have challenges, in geographic access of health services. Even if the services are quality services, the issue of distance remains. When we analyze, we find that people who are near the health facility, are more likely to be in the health insurance utilization. And so that remains one of the challenges. The other challenge also being some conflict. At some point, I think around 2001 there, about, before then, there was user fee for service. Those who were already in the healthcare system, people would pay something little to contribute to their healthcare financing. But the politics of the time thought it wise that fee for service is abolished. Now people have this thinking that healthcare should be free. And we know very well across the world, there is nowhere. There is no single country, by the way, that can provide quality services to the entire population. Yes, there is some taxation, and it also varies how much we tax in Uganda and how much we go for insurance. But now with that conception that health services should be free, it has also been challenging for some people to appreciate payment of premiums, which expire. Say you have to pay every year. Someone say, I paid, but I never fell sick. Do I have to pay again? And you say, yes. Then you say, no, I think these people are cheating us. And so there is that kind of mistrust. People still have issues. Even, for those of us who are who are employed in the private sector, I used to see some people refuse deductions for, statutory deductions, say for NSSF. But I think now NSF has gone a long way, instilling confidence, But people would say, if you pay money, that will be the end. I don't want my money to be chopped. That's the word they would use. Yet it's for their benefit. So the same mentality affects payment of premiums, that kind of pooling of resources. So now when we talk about the National Health Insurance Scheme and people paying, there is that kind of resentment. Our money will be eaten. You see? And then the other challenge with these community health insurance schemes is how one would guarantee quality service. And quality varies, the definition. I have had challenges, for instance, people come and say, for us one equality insurance, when we come, we are given a raw deal. We are given only one kind of medicine, like Panadol. I had people talk about Panadol a lot in the previous session. And yet someone else has come and gone away with 5 different kinds of medicine. They think quality is, where you have a heap of drugs taken home. Yet not knowing that this has been their advantage because they are coming seek health care early. They are not that sick to require, they have not had complications. But they think because they have not gotten the same treatment that the other person who is not insured, therefore they have been given a lot of it. So the quality of care. And then how shall we do this kind of accreditation to ensure that health facilities across the board provide that kind of minimum health care package that is acceptable, affordable, and considered to address, the health care needs of individuals. So that is all I can just mention of equal health in India, and I hope we shall interact further. Thank you.
Thank you so much, Doctor. That was wonderful. I think the major discussion was on accessibility of health insurance, which more or less helps to relieve the financial burden on accessing quality health services. And just to, engage even further people to make sure that the thought doesn't go in the wind, accessibility to health insurance is not any different from accessibility to health services. You mentioned that very many people, especially in those lower areas, who some people call people at the base of the pyramid, find it even very hard to get information about these community health insurances. Statistics show that only about 70% of the Ugandans live within 5 kilometers of the health facilities. Do you believe this is still a challenge in our way of accessing health services, and how can we innovate around such challenges? I invite Dr. Ronald to give his opinion about today's theme. Thank you.
Thank you so much. I'm Dr. Ronald from Rochelle Community Hospital, Clinical Director. I have comments about our health system. One is that I'm good for the government for the step it has taken, because as we're aware that our health system is supported by government and also in the private sector. But it has done a fair work, a good work towards the progress. But still, the population growth is going faster than the percentage of the budget that is supplied by government. So definitely, the coverage can't be as we would wish. Now, concerning the remaining part, what the government cannot provide. So, as we have from our DHO, the informal sector, which can't go to the formal sector, which has a best case insurance, we need to go in and also empower them. And I believe as we are moving down to the department model, I think those also, since they will be organized in a way that the community has a capacity to empower themselves, can be an entry point into how more can they organize after getting those incomes to service some of their health needs. And then number 2 is that the work the government has done to the health to be decentralized. We know our health system has been decentralized, and actually the big part is covered by actually the central government and local government. And for us, we stand in the local government system. So there is how the health sector in local government is disputed has been a challenge, especially for us who are frontline workers, in that the budget that's available to give that the quality service to the common citizen in the health center for which would be nearer to the population than the district hospital and the referral. We have many challenges there, whereby the budget cannot afford having enough human resource, and also if they are there, the leadership of the district sometimes is not very keen in that the health indicators that all these health centers are supposed to move and supply to the DHO's office in order to know, to see where we are working. Sometimes the leadership and support supervision, I think in totality, has not been enough, according to my own observation, whereby even the in charge may know the health indicators required for his facility, but the rest of the team are not really conversant what is expected of us. So you work hard, you get very tired, but actually you don't meet the indicators. So there's a need for strengthening of the leadership and management of the district health system, so that we can see all these things sorted. Because from my experience, it's very hard for a mother to get a rupture if he comes directly from the community and he reaches a health center for which is within a space of 40 minutes or 1 hour, either on the border, or the bicycle, whatever it may be. But assuredly, as they move higher to look for the services at the district, which is more probably 2 hours, or the referral, which is about 4 hours or 5 hours, definitely they rupture. So I've seen experience from this system, the LIBF system, where now we pick the people from home, but unfortunately, because the health center falls and are not strengthened, you find you pick them to the district hospital. That's again, I think, more wastage of time and resources. So that we could get the patients managed appropriately at each level, and then they are sent to the next level if necessary. And I've seen it working during the time I've worked. So by the time I was volunteering in Center for, I don't remember any person who ruptured, because I was there volunteering. That means the human resource, I was one of them. So if we could strengthen the health center for the lower facilities, that they do their work and refer the remaining work to appropriate place. So that's part of the leadership of the districts and the rest. Now, the one I would like to end with is the affordability of our health. So I manage the NCD clinic at the hospital, and I've realized that the drugs which are available on NMS, sometimes some clients do not fit in that category, that you need to put more drugs or more investigations or investigation. So that becomes a challenge to a common citizen who has raised only 10,000, for example. I know there are some who don't even have that one. So how do you cater for them? So I've seen, as the teacher has said, these local, they call the local community groups. So I tried to make one, although I wanted to make it locally. I got resistance from the supervisor because it was not in the legal framework. But whenever I talk to the clients, they were okay to put resources and afford for themselves some okay investigation. But it's a bit, in the legal framework, it's a bit difficult. And then for the sector which is for private, I'm happy with the new NDP 3, which has moved ahead to support and also to work with the private sector. As we know, 50% of our healthcare is actually private. So a need to even strengthen the private sector such that their services are a bit affordable to the population, such that they don't get the right services but at affordable price, maybe by subsidizing the taxes that are levied on them, and also support in terms of different ways, whether human resource, whether to build public partners with the government in here. Thank you so much.
Thank you so much, Dr. Ronald. You raise very important issues, and I want to task the next person as you give your submissions towards the end. Could you give us some of those, strategic actions that you think people at every level could take? At the technical level, innovators can innovate at that, at policy level, and also at implementation level. What are some of the actions, that we could take to address some of these challenges that have so far been raised and those that you're going to raise? Thank you. Maybe we could get another mic to save time.
Thank you so much, Brian. I'm Ivan Mujini from Kamangi District. I'm a medical lieutenant for Kuni General Hospital. Kamangi is a remote place, so I'm going to share experiences maybe from remote settings. We also have refugee populations, so we also have that kind of experience. Yeah, we have a lot of facilities in the district, with facilities, and I think I can say we are trying to achieve much with support from maybe government and partners at all levels. Yeah, the VHT strategy is working well. Our VHTs in each village, I think, are doing quite well. They had some training some time back, and they have been equipped with some other, maybe, I say, refresher knowledge, especially management of common conditions. So I can say we have active VHTs in each village. At village level, we are basically relying on those VHTs to be our eyes. We have given them RDTs to handle maybe malaria, ACTs, to manage malaria, simple malaria at the village level, and that has helped us to reduce the burden on health center tools. Of course, like any other person, we're also experiencing challenges in accessibility. Our places are so remote. Means of transport is border. So for everything is actually border. Our other facilities at sub-county level, like in other places, center cities, where we can expect to find mediums. Our outreach system, center tools, has actually not taken good effect. The plan was like to have a center 3 and center 2s around. The center 3 can support center 2s with midwifery services. That one is not happening. That's one of the biggest challenges why we are actually failing to handle a maternal complication at village level. But for routine outreaches, maybe antenatal, what those ones are going on very well. So we have at our facilities, Lower Facility Center 3's first, you very well know that the staffing we have in the country, I think, is for 2001, whereby I think how 3 million seat, no Center 3. That's the maximum, that's a ceiling. That's of course a big challenge. Now it happens in this kind of epidemic era. If you have 3 millions, maybe 5 nurses, no Center 3 of a population of 20,000 people. How do we arrange them at the facility? So do we put more at triage, or we put more in the ward? That's the challenge we are having. Anyway, but me personally, I would choose to put more staff at the reception on triage. Exactly that's what we're doing like now. We have a better scale in our neighborhood. We're neighboring Chegebo and Mureni. Yeah, of course, don't fear me, but I don't have the budget. But we're expecting, that's a distance around 50 kilometers, I think, from where we work from to where the pandemic, the epidemic is. So now we are having our staff there who got some training some time back. But when COVID came, things changed. I haven't seen it here. The SOPs for COVID are not the same as for Ebola. I think Ebola is not touched. COVID was maybe airborne, masks all over, but people are still maybe breathing kubonga, which is also not allowed under Ebola. So now, in our trade area, if you have like maybe 1 or 2 nurses, and people come with fever, what are they supposed to do? So we're experiencing challenges. After all, we don't even have enough examination gloves. We're going to put on gloves for every patient we're going to touch and change. How are we going to solve that challenge? And okay, of course we have overloaded facilities. What are we going to do in the afternoon when people are very tired and hungry? And then have people who came in the morning and are still there to do. What are we going to do to reduce that kind of patient turnaround time? So as village facilities, we are basically looking at with the little staffing we're having, how we're going to produce good services to our clients. How we're going to arrange to make sure there's coverage and someone who came maybe with some kind of simple fever doesn't get complications when he's here at the facility. So with that one, it goes for maybe more triage at different levels. We're encouraging, of course, starting from the village health teams to as a group, to minimize referrals. Try to treat as much as you can. Treat early. Tell people to seek health allergies. So having a lot of people with fevers at the facility, and yet you have Ebola scare, where of course they're saying fever is the first sign. Now what are you going to do in that case? So when it comes to budgeting, of course we're implementing the 40% disease prevention health promotion strategy, whereby all facilities are supposed to put more money, more resources in the community. That one is not happening very well, but I can say we are trying. Yeah, it is really very hard to this quarter, this quarter which has only ended today, we only received I think 50% or less of the PHC budget. Now we didn't know how we're going to have good services with this kind of funding. Okay, where do we put these little resources? Where we work from, the biggest challenge is referring someone to do blood tests from Fort Porto, that's 50 kilometers, or maybe to even Mbarara. So we put most of the money on like lab reagents, of course, to prevent a lot of referrals of mothers. We put a lot of money on buying maybe drugs in obstetric drug emergencies, Ibuprofen, sutures, those ones. So because of course our procurement plan is due to animals can't supply all. So if you put more of such resources and then get budget cuts, what are we supposed to do in this case when the budget has been reduced by more than 50%? So, and there's something which came up recently, RPF, whereby we're supposed to have you produce more results and then give you more funding. It is someone then stopped. I don't know how many of us are still saying RPF, but for us, I think for us, we have not seen any, yet you are actually planned for it. So that means in one or another we have to go to user fees. Yeah, user fees, first we are having like private services, private accommodation, so that you all get the services, but when it comes sleeping, someone who has the money, if you have some side rooms, maybe that one can pay some money to still sleep in the side room. Maybe you can raise some money to pay an extra porter to clean somewhere, maybe to buy some IPC materials. So that's what we're trying to do to close that financing gap. So we have been having challenges in the recruitment. That's at the district level. They are trying to leave most of the work to our IPs. You have a lot of IPs and this stuff. Yeah, and absorbing them is very hard with this kind of structure where it is actually has not been changed for more than 20 years. So now when the IP loses funding, it becomes a challenge. That's one way to find a solution. And then when it comes to recruitment, even there's a lot of political influence. Workers being recruited is actually not on merit. We have some, of course, in the council has everyone has a relative what, and then the chairperson of the says, recruitment must be within, even for professionals. It's hard. At the end of the day, you meet some good people who can bring in a lot of skills. And then, of course, the salary issues, there was some enhancement recently. It started dropping on account. Then the next week, the platinum or microfinance what start coming to say, please, we are offering loans. The salary is actually good, you get motivated, but the same problem you had with little salary can still come with the new little salary you have started getting. So now that means, okay, I think these guys are playing on, they're using, I don't know, yeah, of course we all need money, but if we have a problem of 2 million, someone comes and top up loan, we can buy off the other one. Then you find that the other day you are paying 8 million. That person is not going to perform because within a few months, the other 400,000 which was topped up, that was going to look like nothing when someone has a lot of loans. So these challenges of salary increment, I think is not the biggest problem we're having. The biggest problem we're having is staffing. If you can create more time for people, maybe reduce hours of work, so like maybe someone said 12 hours in Mbarara. I think 12 hours is much, we may not get it. The first patients in the morning are going to get some good services, but those ones who are coming towards lunch, I think they will still be having some other issues. You may end up admitting those ones, even when they're actually not very sick. So I would suggest something about there was when we used to have retention allowances for medical officers to work in the center force. It worked very well. People were rushing there. What about if they do it also for surgery and start to stop sending people to Mbarara and maybe some other special grades? What about if they say we can have those people at the district level and we keep them there? I think that one can reduce pressure from our colleagues at the regional referrals, because the referral system is quite the biggest challenge we're having, with a lot of border fractures, a lot of accidents. I think, I don't know if it is only in Kamwenda where we're having almost a full general ward full of border accidents, fractures, head injuries. And the nearest referral is 120 kilometers, so you can find a CT scan in Mbarara. I think we can have some of these services in district, at the district level. So I don't know if innovators can also talk to those big boys at the ministry to make sure maybe they can have some, maybe change some strategies. Okay? Otherwise, we have much to say. We shall keep on interacting. Thank you so much. Thank you for listening to me.
Thank you so much. And because of time, I would allow the next panelist to give his views in about 7 minutes. Thank you.
Thank you very much, Dr. Brown. I think you gave them an elaborate preamble of what we're talking about. What is the university coverage in Uganda? What is the picture? What is the image? The first question was, do you have significant progress? My name is Dr. Collins, medical officer in charge current Center for Sinjo. Basically, we serve in the remotest areas. So what we talk about is experience vis-a-vis what people want to see. So what I'm going to share with you is what we see. Then at the end of the day, we want you to say, can you go with that, or can you probably change? Yes, there has been not a notable significant progress, but Uganda has moved a step. What do I mean? Look at the previous deliveries we've been having in institutions. Look at the TPAs, the traditional birth attendants. Slowly by slowly, they are phasing out. That gives us a clear picture that yes, there has been a little bit of maybe community sensitization, community mobilization, and the need for them to know the use of delivering from mosquitoes. So these mothers will eventually come, yes. Now we come to the challenge that we have in our health structures. The medicines. These mothers are going to come. After coming, tell her, go and buy a suture. She will say, no, the government has not worked. She has taken her time to come. She wishes your facility, you tell her, go and buy gloves. That one cannot be. Tomorrow she will not come back. She will prefer to go back to TPA who will give her everything. This TPA will use hands, will maneuver to deliver this mother. But she won't pay for it. The moment she comes to your facility and you tell her, no, we don't have fluids, she will not, she probably think that now the health workers have taken these things. Yeah? Look at when it comes to immunization. The government initially had a program that they were rewarding the best districts that were performing very well immunization, and Isinjiro per se was one of the best. My facility was one of the best. We got a double cabin, the one that I usually use in my free time. Subsequently, yes, that one is one of the things that allow us to be mobile while going for support provision and the rest. Subsequently, the government has forgone these things they were doing. Now, what are they doing? They're actually been making it. It is one of the requirements. If you want to get more funding, give us a 90%. Have you immunized 90% of the children in your catchment area? If not, then the fund is going to reduce. But that one is going to also kill the service that we already put in the community. 3, ARVs. I think that is it is one of the areas the government has put in a lot of interest, and their partners as well. Which means the healthcare is improving, because at the end of the day, if you look at the 2030 government structure, they want us to have 0 HIV infections, new infections, and everyone with HIV should be knowing their status. Right now at 95, but of course, if you look at the 95, the third one is very hard to maintain, the retention. We are treating these people, we are putting them in service, but we are not retaining them. So the few that are not being retained, of course, have their issues. Why would someone come to your facility, you test, start treatment, then eventually you fail to follow up the patient or the client? Because this one person is going to now take us back to where we started from the pandemic of HIV. But the reasons are usually there, because we don't have a lot of staff to follow up these clients. The means are not the best. The areas working are very remote. And at the end of the day, what my colleagues have talked about is what I'm coming to. The government has tried again to make sure that we have a structure, a health facility at every level. At the parish or the center 2, at the sub-county or the center 3, then at the HSD, the sub-district or the center 4. But do they have the staff that are supposed to keep on working day in, day out? If these mothers have come to the center 3, I'm going to find one midwife running the whole center 3 from morning up to morning. So when you go back to policy level, they'll tell you, no, the center is supposed to have 3 midwives. Even when you have included deliveries in a month, that is the policy that you have in government. So that is the weakness I think they should look at as well. At the end of the day, you have given us the structures per level. The center 2 is there, center 3 is there, center 4 is there. But now the staffing. You build this building, then you don't put in chairs. We come and we sit down. Work done is not zero, but of course the outcome can be equivalent to 0. So what would you want to do? Let us also look at the issue of staffing, because it is one of the factors that my colleagues are talking about. Give us little money, but let us pay a lot. So that you reduce on our workload, the patient-doctor ratio. You're sleeping in theater, doing 50 cesarean sections. Then the government will say, no, at the center we're supposed to have 2 doctors. Honestly, 2 doctors look after 50 women who have come for delivery, who need to be operated. So at the end of the day, I would also want us to rethink the innovators. Because the health sector is looking at very 3 important things: the maternal child health, immunization, then of course health for everyone, well-being. That is the SGD3 now. So what happens at the end of the day? I would want the innovators in the healthcare system might not finish. What is very important? Information. information, financing, and at the end of the day, service delivery. But how can we deal with each and every component to bring about a better delivery? If you look at health service information system, HMIS, what can innovators do? Probably we have these mothers who go home, have not attended antenatal, but we need to teach them, they need to know that if I start bleeding before I go to the hospital, it is a danger sign. So can we develop an application that will basically teach these mothers something to do with the danger signs if I'm pregnant? Because we're trying to look at the maternal mortality and newborn infant ratio. Can someone go out there and say, if I develop this application, this mother starting to have headache while she's pregnant, starting to have a gastric pain while she's pregnant, starting to see her legs swell while she's pregnant, it could be a danger sign. Can we develop such kinds of things so that we give these mothers, give the VHTs, so that these mothers can be able to make timely decisions to come to a facility? This one, at the end of the day, will reduce our maternal mortality rate, which one of our colleagues talked about earlier. It is still a challenge. Mothers are dying every day. A mother will go home, she doesn't know that when I bleed, it is very bad. She might call it simple bleeding. I bleed today, tomorrow I stop, the other day I bleed. Eventually, by the time she comes, the uterus has ruptured, she has APH. But if you hope such an application for the innovators, I'm trying to emphasize this because I know it is one of the indicators that is very important now in government or in our healthcare system, maternal child health. Can you look at this mother who is coming 100 kilometers to deliver when her leg starts swelling? Can we tell her the implication? Can we develop this application? She's able to, in various languages basically, but I can read it in Chiga, Uganda, very many. Then I wouldn't want us to over-exploit because the conversation is ongoing. Let me give my colleague a chance that we try to keep time. Thank you very much.
Good afternoon. My name is Dr. Mbarara Rashid. I work at Children's Center for Mbarara. We are still new, it's a new district. The challenges we are facing in our community, we expect at least most of the individuals, the communities to access health care, quality health care at any time and at affordable costs. But you realize that most of these communities they are poor communities. Distance also is a challenge. For example, in our catchment area, most of the facilities are health center tools, and they're not providing the maternal child services like deliveries, cesarean section. So they face, most of the mothers now they are facing difficulty in reaching it. For example, coming for antenatal cares. At the moment, the government recommends at least 8 times to come for antenatal visits. But you realize that it's very difficult for most of the mothers who are coming from the rural areas or very far to come for 8 times. This also brings a challenge of the first trimester. Most of the mothers are not coming for early within the first 3 months to seek for services for antenatal care due to distance, knowledge gap, and they cannot go to nearby health facility and center tools where they're not providing. So that also becomes a challenge. So they are coming when you're already 8 months, 9 months, so they are missing most of the services in the first trimester. And that puts a big challenge to our community, that people are not accessing quality services. So we need at least an application. How do we connect down these mothers to the facilities? Which application can we bring out so that maybe they can alert when someone misses the period that it just knows, maybe it's in their phone or where that just a reminder or what that you can have to go to the hospital to seek for services. There's also a challenge of imaging, scanning. Most of those facilities, they don't have scanning. So most of the great mothers, they don't do scan. Those who are lucky, they do this one scan. So you find that now the health workers, the doctors, even go to the theater without knowing the results. You don't know what you are entering in. You just open and find out, hey, there's this and so it's a very big challenge in the communities. So if there was a way, maybe you can use a phone to act as a system in a phone that you can try maybe to look for the basics for health workers, it can help a lot in the lower communities. The referral system is also not updated. We expect that this a person start from the VHTs, center tools like that, but the system is not well organized. The referral system. When you get a problem in the village, people expect to maybe rush you, for us maybe in Mbarara, rush you direct to Mbarara. Instead of going nearby facility where they can serve you. So in that process, even a person dies on the way before reaching. But if there was a way, that coordination, how we strengthen our system, the referral system in the community, so that it's direct. Someone knows that when you get a problem here, you go direct to the another level until. Also, there may be that system may be there, but how do you also streamline it? There's a lot of violences in the community. Most of the people are brought by borders to local facilities. So they're even adding more harm to the patient. We don't have, most of these, first the government facilities were funded by the government and some NGOs. And we expect people to get quality, to have all the medicines all the time, which is a challenge. There was we had a challenge in our community. We had very many non-communicable diseases like diabetes, hypertension in the community, but people were not aware. Because people who come to the hospital, the government will supply just very little essential medicine for hypertension, diabetes. So when they get finished, people cannot afford, they just stay in the village. So we're getting a lot of complications as a result of hypertension, diabetes in our facilities, stroke. So since we didn't have a scheme of support to add on to supplement on the medicine we receive, so we had to come together, and then we formed clubs for people who are living with non-communicable diseases, for them to support themselves. So they could come together, they could put some money, just like a scheme, a local scheme. So that when the medicine which are supplied by the government, they get finished, they can contribute. So we have to link up with the joint medical stores, and then also get at a lower cost medicine for them at a lower cost. So that will also reduce a lot, to reduce those incidences of stroke in the community, because people will come together and also support themselves, support their colleague. Those who are sick in the community will go there and support, and then, so if there was also a way of organizing those groups, and also have that system that we have this number, and these are people who can support each other. When maybe a colleague gets a problem, maybe just also allows the find a way of supporting them. So,
Dr. Rashid, I'm going to ask you to finish quickly, and then you hold your thought in there. At the end, I'll give you a minute to kind of give a summary of that for the interest of time.
Thank you so much. Staffing also, as my colleagues talked about the staffing level, is also a challenge. For example, there are some departments which are very busy, plus like antenatal, maternity. They are busy, but at the same time they have a lot of paperwork, hard copies. And these ones are not, we need maybe if there was a way of comparing, make a system which can compare most of these together, than we have few staffs, again they have a lot of work. If it is one staff, again we have permanent files, you are recording, and that's what the nurses also are complaining, they become tired, they become disorganized because they don't work. You have 100 mothers waiting there, you have files to record, you have a lot of documentation. So that area was also important. And then lastly, I want to also talk about the battle graph. This is about quality services in maternity. The photograph also has a challenge. We realize that most of the midwives are not real monitoring using that photograph. Utilization is not so good using the photograph. Because it's very hard, not practical. One midwife you are delivering, and then you are monitoring the motor action, you are fetal art, and then you are recording here. So it's not also being, that's why we are getting the maternal deaths, because it starts from the monitoring. Was this mother monitored well, use the photograph? This manual photograph. So if there was no doing it electronically, and then see, we can look at that. Thank you so much.
Thank you so much, Dr. Rashid. Thank you so much, our dear panelists. And we are running short of time. We have about 10 minutes to finish, and therefore I'm going to request the audience just one question from here and one question from there. Preferably a lady and a gentleman. Yes. So he was the first put up the hand. Please give your question. In a minute, just hit the point. Thank you.
Thank you so much. My name is Mbarara Dominic. I work in the COVID treatment unit at Mbarara General Referral Hospital. Focusing on the theme of the event this the theme of the event this year. Mine will be just a contribution, not a question. First, before building the resilient healthcare system, but still we can come up with ways how to do away with these pandemics. One is how quick can we identify the index case, because it's this index case that brings about the outbreak, the endemic, epidemic, and definitely the pandemics. Then secondly is decentralization of services to lower facilities. Yes, we appreciate the era of COVID has brought about decentralization of services, for example, PCR services, regional referral hospitals, with the gene experts being introduced to regional referrals, which has quickened the diagnosis of these pandemics or these viruses affecting or bringing about the pandemics. Then the other one is the role of the private sector in the issue of pandemics. We all agree that most of the patients actually go also to the private sector, but how can we connect the results or whatever findings we get from the private sector into the mainstream? For example, in the COVID pandemic, currently the cases that we are getting, they come from the private sector, which are the Asians. But how are we dealing with these cases that we are getting? For example, doing genomic sequencing to find out which virus are we facing, because there are these viruses actually that bring about other surges of pandemics. Thank you.
Thank you so much. Let's have a lady from this side. Wonderful input. Any lady from this side in a minute? Yes, thank you, Christy.
Thank you. For me to build a resilient healthcare system, we need knowledge, the right knowledge, and always current knowledge based on evidence. And we have a lot of research being done, a lot of new innovations coming. And I observe that in the public healthcare system, we always have continuing professional education and continuing medical education and continuing nursing education. However, those who are in the private sector, the clinics, to the most rural setting you may think about, I'm just wondering whether they have opportunity to receive this information in time. For example, we're talking about the new pantograph. We have a new pantograph in place. I only saw it on WhatsApp group. But some of these rural communities do not have access to smartphones, and they use the small phones. So this is my thought. My thought is that if we could have a system in place for continuing professional education for everybody in practice, and all these people who practice, who have practicing licenses, are expected to subscribe to, so that one, we monitor that they are actually having the continuing professional education required, and what kind of continuing professional education, what kind of issues are they trying to improve their knowledge and skills in. I think that would be an innovation that would improve on the healthcare system. I thank you for listening.
Thank you so much. Christine, I hate that I have to end the audience discussion there. I wish we had more time. I want us to come back to the panelists and give them a chance to say goodbye, but before we say so, just take a few issues that I feel have been so much hinted on. One is accessibility of healthcare services, then skilled workforce, the low skilled workforce, and how can we innovate around the challenges in these health facilities amidst the low skilled workforce. In the health facilities where we have very few health workers and maybe they have to do multiple tasks, how can we innovate around some of these challenges? Then areas around information gap, dissemination of information and lack of information, financing, then healthcare delivery to the lower health facilities, referral systems, imaging, and also empowering the low healthcare workers, especially the VHTs. People hinted on that the VHT strategy is working well, but it is not well empowered. How can we innovate around, strengthening this, and also the outreach system to the lower facilities? I know there are quite a number of issues that I have not hinted on, which you have picked, and I pray that tomorrow will be a day that you can, actually starting an hour ago, that you can start thinking about how to innovate. I want to give each of you less than a minute. I'll cut you short, sorry if we go about, and I'll begin with Rashid this time.
Dr. Brian, I think we have discussed most of the things which are affecting, especially for us who are working in the lower facility, the poor community. So we need to think about them, we need to think about saving their lives. Because we expect all of us to access these quality services without any hardship. So let's come together and then support people also in the community. Thanks so much.
Thank you very much, and thank everyone, colleagues. Basically, I have to take 4 messages. One, let us look at systems thinking. We are in a system. We are tending towards, I think, a digital era. Let us go to systems thinking. Which systems are going to put in place? There is a system called prisons where you work on the phone. You deliver a baby, you don't understand something, put in. They will send you the management and the symptoms. You can save a baby from there. Systems thinking. Later in the day, let us look at system strengthening. Someone talked about knowledge. We shall be looking at capacity building of these workers. We picked 1 or 2 things. We shall be doing what we call system strengthening. So at the end of the day, we shall look at system thinking and system strengthening as a way to go to try and address these challenges happening in the sector. Thank you very much.
Thank you. Mine is not different from his. We recently bought around 19 computers for our facility, one for each department, to improve data capture, electronic data management. It didn't work actually. I think like some of them are already been storing because we are not using them. So dear innovators, I don't know what I'm going to do to help us in the rural facilities. It's working in private facilities, I think it can also work with government ones. Can help us see, can we do electronic data capture, recording and reporting to minimize wastage of time and paying patients. Thank you so much.
Thank you so much. I'm Dr. Ahmed. My closing remarks is that the leadership, the management systems concerning healthcare, right from above, from the ministry, to really go in and add more health financing, and also at our each and every person's level, to be interested in actually the key outputs and the indicators, as you have said. And also the last one about communication and referrals. I think if you can finance probably like a table phone, and maybe you will give it the solution to the community. Even everybody has a phone for your emergency ward or maternity ward, so that some of these can either ask questions or seek for clarification, and also probably if they are coming, then you prepare for these clients. Maybe it can help.
Thank you so much. I want to end on the note that universal health coverage is still a long way away. Out-of-pocket payment still stands about to 42% of the healthcare financing, meaning that most people still pay from their pockets. And a very good percentage of the population is driven into poverty by catastrophic health expenditure because they are paying much at the time they are not working, at the time they are sick. So I think the areas we should be focusing on as innovators is how we could sustain health messaging at community level, especially appreciating the fact that universal care coverage requires multi-sector approach, thinking about innovative ways of healthcare financing. How can we put more resources into healthcare, into the health sector, such that the most unfortunate, the poorest of the poor can also access quality healthcare services? Then medical access to the remote areas. Are there applications that are good for use as telemedicine, triage, and so on at community level? Can someone who is in the hills at the border with the Democratic Republic of Congo in hiding from the M23 be able, in his enclave, to just quickly get to know that they are unwell and this is where they can get their medicine? It can be delivered in any innovative way. I had someone talk about drones, perhaps there could be something else. Civic education, dissemination of this information, talk about knowledge management, but in institutions. What about, at community level? Because I think all of us ought to know our responsibilities as citizens. And if we did, then some of these things, as putting resources together for healthcare, wouldn't be such a big challenge. So at policy level, I think those are some of the things that they have to be looked into. And of course, knowing that, former DGs used to say that, health is made at home and made in hospital and facilities. Therefore, it is a responsibility of everyone, and that information needs to be there. Staffing and delays in hospitals that actually determine the quality, because if someone comes and waits for 2 or 3 hours, tomorrow might not come. How are we harnessing these technologies and how can we improve? In the past, for example, in Tanga thermometer, there used to be mercury thermometers, and you first check it and then read, you test it. But now you have a digital thermometer, you have a digital whatever. Has this translated into reduced waiting times? How are these technologies, working together to improve patient experience? And I think it's maybe one person can look at the configuration, the different configurations of these technologies can be put in use to improve patient experience and access healthcare to the most in need. I thank you.
Thank you so much, our dear panelists. Thank you so much, the audience. Like they always say, there are 3 kinds of people: those who watch things happen, those who wonder how things happen, and those who make things happen. I'm so happy that I'm surrounded by people who are ready to make things happen, solve these challenges that have been raised here. On my own behalf and on behalf of the Department of Community Health and Camtech, we are truly grateful for being a very wonderful audience. I didn't know that filling the shoes of a professor is not that easy, but we finally come to the end. Thank you so much. I wish you the best of the day and the rest of the day.
I think these people deserve a much bigger clap. I also want to warn you that after this you are going to eat. So whatever energy is left with you, please let us clap for this thing. I thank you, Brian, for fitting in those big shoes. You are becoming a professor very soon. Friends, we have been discussing universal health coverage, looking at the perspective of Uganda. And what the panel has done very well is to identify what we can do best. to make sure that we move at least a few strides from where we are. Colleagues, at some point I used to be a teacher. How many of us know the universal health coverage day? We have been discussing universal health coverage. So who knows universal health day? We wouldn't be discussing P7 in this room. Friends, before you go for Christmas, 12th of December is the universal health coverage day. What have I been listening into, especially Dr. Data and your team and everybody who is here? A couple of things. There is poor infrastructure that is affecting this coverage. And this, it doesn't matter where it is, because I had some people say in the private sector it looks okay, in public it's bad. But how many of the communities that we serve can afford to have medical care from the private sector? You remember during COVID, and the charges, especially for Uganda, 100 million, and these private facilities even had to hold, some bodies before they got their payment. Number two, for everyone who is here, is that poor health facilities, poor health policies is actually a big challenge, because like our colleague from Windi has said, they tried community health insurance, but it has faced several snags. And so it remains a challenge that each one of us and the people we care about have to have out-of-pocket expenses. And these are keeping us extremely poor. So could we have some innovations around that? The next one that came very strongly is that there is shortage of health workers. And where they are even low-skilled workforce in place. You know, it is only during COVID that medical workers would be stopped by security people who are taking, temperatures on the gates. That had never happened. And I imagine these askaris had never received any form of training at all. The other one that has emerged properly is that we have expensive quality medicines and medical products. And at worst, we don't have essential medicines. And I also wanted to mention from my engagement with the team is that we need most likely to bring in the biomedical engineering teams in this equation. Because recently we are realizing within our own regional referral hospital at Mbarara, there is a lot of breakdown of essential equipment, repairable, and we are not using them, and we are referring people everywhere, when in actual sense, what has stopped this equipment from functioning is a mere fuse that each one of us can actually pay for. So I think that's an area that we might need to bring into the equation. The other one is that there is lack of access, and I think that's why we are here, Dr. Data, to digital health and innovative technologies. Poor and unstreamlined referral system, and sustainable funding, especially from NGOs. The other day I wanted to go to Kawianga and I passed in the hills and went to Hira. That place that used to be the home of Millennium, what was it called? Millennium Village. Most likely the Millennium has passed. The village is still there. It is a sorry state. It is a very sorry state, unfortunately. And we know how much equipment we have at our health facilities that were bought very expensively by NGOs that we can no longer use, including vehicles, because of their consumption, high consumption rates. And the second last thing I picked is that there is limited information and expertise sharing. I think this is somehow unfortunate. I think I was also in Kamyan and someone was telling me in the next health facility, there is a specialist who can help us do this. But unfortunately, we can't contact them. What does that mean? Is there something we need to do in this hackathon? And of course, what has emerged also very strongly is that we know we are well-trained medical people, but that we cannot do it alone. So the integration of VHT system in the treatment and referral and that kind of game needs also to come out very strongly. And while all these things were still prevailing, then COVID hit. And what happened? Mental health disorders increased as a result of anxiety, as a result of lockdowns. The first lockdown, people started walking in roads, on highways, and the President of the Republic of Uganda stopped that because that would actually enhance transmission. And so lockdowns, joblessness, all these impacted the challenge of universal health coverage, at least for our Uganda's perspective. Colleagues, we will have to end on a note by bringing in two people. This one up. I can guarantee, as per the discussion from our Vice Chancellor, we are going to have to be active for lunch, and then after that we come back and have the afternoon session. May I now invite Dr. Data, the country manager of Camtech, to come and give your closing remarks. And then after that, we invite Dr. Stephen. Thank you very much.
My closing remarks are all going to be given by Dr. Stephen, but in my capacity as the country director of Camtech Uganda, I'd like to take this opportunity to provide information. So, we've had quite a list of challenges, and you've had the opportunity to see where these challenges are coming from. At least you've put some faces to the challenges. And these people here are content experts when it comes to the challenges that they have what? Presented. So following here, please walk to them and talk to them and get more information about what? The challenge that they have shared. Because our collective wisdom together is more powerful than any challenge that is in this room or out there. But when we apply wisdom of one person, it's very easy to dive into the psychological value of death. Okay? So in the afternoon, there is going to be a very interactive session on human-centered design. So then, see how science has evolved to try and see how you approach the process of developing a lasting solution. As Professor Obua said, the solutions need to be impactful, they need to be practical, and they need to be sustainable. For them to be sustainable, you have to have the end user at the center of the solution. So I want to welcome you all to the after lunch session on human-centered design, and after that, continue the interaction into the cocktail in the evening. Thank you so much. I'm now pleased to invite Dr. Stephen Asimwe, my boss, to make his closing remarks.
Thank you, Doctor. People like bosses. Good afternoon.
Good afternoon to you. Secretary of Uganda Medical Association. I will take minutes. I was the youngest in the room. And at that time, most of the seniors were like surgeons and physicians. So I told myself I'm not really seeing what healthcare is. So I went up country and began my career in Kagando Hospital. You know where that is? In Kasese down there, the ADF was still there. I spent a year, and what my colleagues were describing, I saw firsthand. ADF was there, we did a lot of surgery. Then I realized maybe I don't want to be a surgeon. So I went to government. I ended up in Tagata Hospital. Deep. I worked there for a year. Same challenges, same issues. Then to Rugazi Health Center 4, which was taking master students. I think I ran that place for like 2 years. Then at DHO's office for a year. Then at Kahoe Health Center 4. But what did I learn through all this? I realized that, and actually it came to dawn on me a little late, that in Uganda, our population increases faster than we can think or we can allocate our resources. By the time that realization came to me, I already had 4 children. I said, I should have had 2 children. In the health center 4, at that time I had a budget of 140 million. The last budget I planned for PHC, 140 million. For a health center 4, over 100,000 people. They would estimate a county to have 100,000 people. I don't know, colleagues, how much do you budget for in 2022 for a health center? Any volunteer? How much? 60 what? 65 million. So every quarter, like 15 million. And the population in 2020, in 2000, what was Uganda's population in 2000? And what is the population today? So, what am I trying to point out to you, dear innovators? For health, there are 2 main areas. There is the preventive service. That's where the public health specialists, that's where now I specialized in coming. And then there is the curative service, where people are going to the facility. But in Uganda, you will find we are always behind, trying to chase that curve. Why? Our ladies are just too fertile. Yeah, there are just too many people. You go to the hospital, go to the health center. So, in a nutshell, we are here to innovate, and to innovate is to do it by solving problems. The biggest problem we have is that we have more people than the resources can handle. I don't know how you're going to innovate that. Are you going to innovate wealth? Money? But in this program, through the Camtech Hackathon, our role and working with our donors, we want to invest money in you to see if you can generate solutions, solve problems. The richest people in the world today are people who solve what? Problems. If you can solve a problem and commercialize it, you will get rich in the process. I just want to distill the 3 problems our colleagues in the morning from nursing and in the afternoon for the medics have been talking about. 3 areas. The first is access. If you can solve the problem of our poor people accessing healthcare, that is preventive healthcare or curative healthcare, you'll get money, you'll be rich. Access to healthcare, access to preventive healthcare, access to a nurse, access to a doctor. If you can solve that problem, number one. Number two, the cost of healthcare. Now the problem with health, it's not elastic. The economists have a word called elasticity. That the more you pay, the more you get. The more health, the more money you have, the better health you get. Unfortunately, health is inelastic. You can have all the money in the pocket, you can have all the education you have, but if you come with obstructed labor at Mbarara Regional Hospital, you might actually get a worse outcome than a poor man. So health doesn't know issues of money, but the cost of care matters because it can be a barrier or an enhancement. So you innovators, how can you help us on the cost of health? If the issue is transport, if the issue is communication, if the issue is all those innovations that can lower the cost of accessing health, you will be rich. The last area is quality of health. Because you see, health is a very interesting construct. Someone quoted the former Director General defining how health is made. Many times you find people define quality the way they want. Someone say, I went to the hospital, the service was excellent. And another say, what are you talking about? The service was horrible. So quality is very tricky. But how can you innovate a quality health service? After here, you're going to go into doing research into these areas. How do people define quality? It could be the duration it takes to get a service, what they call turnaround time. If your innovation can reduce turnaround time, then maybe somebody will say the service provided here or there was a quality service. If your innovation can improve the way somebody feels, maybe somebody says thank you. Whatever your innovation does. So access, cost, quality in solving and getting our people get preventive nursing care, preventive clinical care, or curative care. I think we shall have made wonders. Finally, I don't know, Dr. Data, how many innovators you plan to reward, but this is a marathon. Hackathon comes from marathon. It means it's a race. We are going to begin today. I hope today everybody has, in fair time, what the problem you want to really hack on is. And then we'll take 24 hours running with the brain, trying to come up with a solution. Now, as you know, at the end of each hackathon, there are what? Medals. Gold medal, silver medal, copper medal, all those medals. There will be money that we have to offer people who come up with the best solutions. So thank you so much for participating and turning up. Our visitors from Burundi, we really love you. Thank you for supporting this endeavor. We are all in the community together. We want to generate and solve these problems that our people are facing. And I hope and wish you a fruitful hackathon beginning this afternoon. We'll be available to advise and chip in where necessary. I'll be around all the time. You can approach me for anything. Thank you, Camtech, and all organizers. God bless.
Thank you, Dr. Stephen. I think he ended on a good note that there is money to be won. There is money to be won. We are going for lunch. But as you go for lunch, please already start looking out for people with the same mind. Don't sit with the same people you came with. That will not win you money. And be sure that this full house is part of our accountability. We are going to have our group photo right at the entrance of the hotel. And Rina is going to lead us. And Mary, do you want to stand? because this team is standard. So Mary is there. Let us all follow Mary, have a group photo, and we're going to have lunch from the restaurant down. The afternoon session, Stephen asks me to talk about the afternoon session, which Dr. Data has mentioned. The afternoon session is starting at 15 hours. Hey, that's the lunch thing. Oh, yes, 14:30. And like Dr. Data has mentioned, it is going to be user-centered design thinking. Are your solutions having people in mind? And that is a bigger school of thought. Thank you very much for the morning session. We really appreciate you. We are sure that by the end of the day, we will have found colleagues with the same minds, and then Saturday and Sunday, we will all emerge winners. Thank you very much and enjoy your lunch.
Mbarara, those of us who come from within. My name is Nambogo Nuriat. I work with the Consortium for Affordable Medical Technologies, Camtech Uganda at Mbarara University, where we work with innovators and guide them through the innovation process to ensure that they bring their ideas to life. Like Rama already mentioned, I'm going to present, to deliver this presentation together with Dr. Data. Dr. Data will lead us in an exercise. We are going to have a simple exercise after or towards the end of my presentation. So we are going to look at user-centered design, which is design thinking. But I would like to throw this question to every one of us here. Because by the time you applied to participate in this hackathon, you knew you wanted to, most of us I think here, wanted to innovate. So what is design thinking? Just like your hand. Who can give us a simple definition of design thinking? Just simple. When someone says design thinking, what comes to your mind? Yes? Do you have a microphone?
What's wrong with putting it here?
There's someone in the corner.
Okay, never forgive. Why you put it
Design thinking.
You told us so.
I think it's about putting onto the paper the imaginations you have within your mind to give the output for it.
Thank you. Putting on to the paper the imaginations you have in your mind. Who is next? I just want about 3 people. Yes?
I think Edward Retire.
I think Rama is busy. Maybe you can help. Okay, thank you.
I think design thinking is coming up with a solution to a problem.
Coming up with a solution to a problem. Okay. Okay. There's someone beside them.
Thank you. I believe that design thinking is having the, if for example it is an application, how will someone be able to use it? You have that in mind, at the back of your mind. How is that last person going to use it? How will he or she be able to use it?
Okay. Thank you so much. Your answers are all right. One last one.
Design thinking are the procedures that one follows, the step-by-step procedures that one follows in order to come up with the idea.
Okay, in order to come up with an idea. Thank you so much. So design thinking, it's user-centered design, like we said. It's participatory design. How do you engage the person you're designing this solution for? So you make it participatory because you're not designing it for yourself or you're not developing it for yourself. And according to Tim Brown, the CEO of IDEO, he said he defined design thinking as a multidisciplinary human-centered approach to innovation and problem solving that integrates the needs of people, the possibilities of technology and requirements for business success. So we are looking at needs, we are looking at technical feasibility, we are looking at the business part of it. Because as an innovator, you're not innovating for charity. You innovate and develop something that should be able to bring you an income. So as you start thinking about your ideas, think about something that should bring you money or should bring food to your table. And design thinking looks at three aspects. One is desirability. What do people desire? Remember, I mentioned that you don't develop for yourself. You develop for someone else. It's like someone having a boutique and you want to buy everything that you feel you like as an individual that should fit you. You're kicked out of business. So that is the same thing that we apply here in design thinking. So what do people desire, not what do you as an individual or as the developer desire or as an innovator desire. Two, it looks at viability. Before we look at viability, feasibility, the technical aspect. Is it actually technically feasible? You're proposing something, maybe to develop something that should be ABCD and it's a big device, for example. But is it something that is feasible technically? Can it be developed, or you just have an idea in your mind? And when it comes to development, you cannot actually have it developed. The third one is viability, the business aspect. Can it bring money to you? Can it bring money to you as an innovator or as innovators? Will it be able to sustain itself, even if you get grants? Even when you're applying for funding, they will ask you, what is the sustainability model? After this grant is gone, how are you able to sustain this business or this product in the market? So design thinking has a process with 5 steps. The first one is, empathy. We are going to look at each one of them. The second one is problem definition. We have idea generation. We have prototyping. We have testing. Right now, most of you, I think you have already, we shared challenges. You have already, by the time you applied, we asked you, there was a question that was asking about the challenge that you would like to work on during the hackathon. So I'm thinking you hear the innovators especially, maybe mentors may not, but the innovators, you have already something that you're thinking about, which you're going to pitch tomorrow in the morning before you start forming groups. So those are the steps. I'm going to talk about each one of them. Empathy. Empathy looks at, can you put yourself in the shoes of this person that you're developing for? It looks, so you learn about the stakeholders for whom you are designing this innovation. You engage them into interviews, observations, try to, or if you're developing this for a pregnant mother, a solution, maybe to support a pregnant mother in something, or maybe, you know, the pregnant mothers in their late stages and maybe they are dragging, they find difficulties in walking. Can you put yourself into their shoes? Can you engage them? Can you go to this hospital and actually look at how they are doing this, how they are interfacing with the problem? Okay? Then engage users, technical experts, and then other stakeholders. Because when it comes to building, maybe on the team, that will be mentioned maybe tomorrow. You need a team. You cannot be everything as an innovator. So you cannot say, I'm going to work on a solution as an individual. You need a team that is multidisciplinary, that will support you to work together on this solution. Then you look at journey maps. How do these people interface with the problem? How do they actually go through this problem? So you engage them to try and understand how they are interfacing with this challenge that you're interested in. Problem definition. You now start defining the problem. Develop a meaningful and actionable problem statement through synthesis of observation. The interviews that you have conducted, maybe like even literature. So we encourage innovators like to write a concept. At Camtech, we teach people, we conduct scientific writing workshops. And before you even start talking about your solution, what is key, the most important thing is the problem. If you don't understand the problem, then you don't understand what you're going to develop. I know it's common for innovators to be excited about the solution. You know, I want to develop this and this. It should be working. But when you sit down to ask them, if you ask them about the problem, they actually struggle to define the problem. So you find you're developing a solution that has no problem that it is going to solve. Because if you don't define it well, you would rather spend more time defining the problem than spending time and getting excited about your solution. Because when you get up there, you will be kicked back because you did not understand how it affects the people that you're developing it for. So problem definition, engage the design teams, of course, to think through this problem, together, because when it comes to development, you're not going to develop it alone. And that's why we emphasize that it's good you work as a team, or you outsource and consult people of different disciplines that can support you to develop this solution. Then clearly define the problem, incorporating primary and latent needs. Latent needs are those hidden needs. We call them hidden needs. Those are needs that are not paid to attention by the previous developers of the solutions or the solution. For example, it can be, what example can I give? So as an innovator, you look at those insights that people who developed other solutions have left out. And that's where the user needs a solution, because remember, you're not the first person to develop a solution towards that problem. Are we together? If it's a problem of making sure that maybe mothers get to hospitals or mothers do antenatal checkups at the right time, you're not the first person to develop such an application. There are so many applications. But so many solutions, they may not be applications. There are many other solutions. For example, look at Uber, look at, which other one? The transport. Safe Border, like each one of those they do have their uniqueness. And the uniqueness of your solution is you tapping on the hidden needs, okay? Or the latent needs, the hidden needs that this person who developed the current solutions did not pay attention to. And that makes us also improve on what already exists. For example, maybe Mama, the one that provides warmth to babies, kangaroo mother care. Maybe someone else could develop something that is better than that, basing on how this one operates. But it all comes back to you trying to understand the problem and defining it. Ideation, remember you're working as a team, and we expect that tomorrow we are not going to see people working as individuals. So you better start engaging and talking to people, so that when you stand up to present your challenge or to pitch, you call upon people to join you, and they will be able to join you to provide a solution together as a team. So when it comes to ideation, remember now, you can say maybe let us go out, let us go to hospitals, engage with mothers, talk to them, try to understand this problem. When you come back, you now start presenting, okay, how do we want our idea? How do we want our solution to look like? And that is best done during the brainstorming sessions. And to brainstorm, to bring up their ideas. Of course, after presenting whatever they will have discovered, remember the other ones are the first stages, okay? The problem, after understanding the problem, you'll come back and, present what you got from the field, for example. Then when it comes to ideation, same thing. Work together as a back, present let people be crazy about what ideas they want to put on table and then discuss them. So brainstorm creative solutions for the identified challenges the identified challenge. Then engage the design team, bank on solutions. I want us to go to this. There are some brainstorming techniques during ideation. One is, of course, you have to work as a team and set roles before you start brainstorming. Some people will use sticky notes and have a whiteboard or anything that you want. So let people, you can use also like these sticky notes and write your ideas and put them on the board. Build on ideas of others, encourage wild ideas, express ideas visually. Let people draw, let people write whatever they want to write. If someone is saying, I think our idea, our solution should be like this, let them draw it, okay? And after, you will do a voting, of course. Mount voting, you do down selection, whereby you see which ideas can be merged. Nuriat could be having a similar idea with someone else, or maybe three of us. Can you find a way of merging it, how you're thinking this solution should look like? So merge those, it takes some time, but you work it out as a team. Try to merge them together. Try to see, okay, after merging, how many do we now have, okay? That is down selection. Selection of multiple solutions, you can have like 3 or 4 because you are a bigger team, but now when you do down selection, you come up with like 4 ideas. But out of the 4, remember you want only 1 that you will work on as a team. So what you do, you can also do voting, voting. Say, we are 4 team members. Remember, we respect each idea of each individual, but you want to come up with 1. So if we are 4 team members, we have idea A from Nuriat, idea B from Solomon, idea C from, and then you say, okay, everyone is going to vote for their best idea. So I can vote mine and then I vote for someone else. So you go on voting. Now the one that gets the biggest number of votes is what you take up as a team. Of course you have agreed, you have discussed through it. By the time you come to 4, maybe some can even tell you, say maybe 2 are getting the same votes. So you still can vote again. We move on to prototyping, which is the 4th stage in design thinking. Prototyping, now you pick up, remember you have now selected on 1 idea that you want to work on. You've picked on 1. So what you do, you start prototyping. Prototyping, build a tangible or intangible representation of the proposed solution. So you can now redraw it on the board, for example. You redraw it and then you start building it. You start prototyping. You can start with boxes, for example. During the hackathon, you're not going to have like big functioning. They can be functioning, but they are prototypes which you will improve on later. You can even use boxes. You say maybe we are using, like whatever is there, you can start with that to build something that is similar to what you're proposing as a solution. Engage technical experts, engage the finance teams, the finance people, users, designers. Remember, we are looking at technical feasibility, the financial bit of it. We are also looking at something that is desirable to the end user. So try to engage them as you're developing. After developing, ask them what they think about what you're developing. An expert, for example, a technical expert, the designer, they'll tell you this will work or it will not work. So if it will not work, how best can we make it work? You talk about it as a team. Examples have examples of solutions that can elicit feedback from user groups. Go back to the users for feedback. Once you have your first prototype, please go back to your user. Remember, there are people you engaged at the start, and those are the people that you're developing this solution for. So go back to them, ask them what they think about what you have before you can actually proceed to the next stage. Okay? And we move on to testing. You have to test the tangible prototype on users, for example, in groups or for feedback. So make sure that you go back and test how it works. And I'll give you an example of one of the innovations that we developed, that we took through using the design thinking approach. So design thinking, this is how it looks like. At the start, where there is empathy, you see a lot of zigzag, like you're not sure what you want to develop, and it's normal, it's okay. You're not sure, like you have so many crazy ideas that are not connected. That is very fine. So you do research, then there's a lot of uncertainty. You try to pick insights from the users, your intended end users. You engage them as much as possible, but also do literature review. Read. There are so many publications about the area that you're trying to work on, the problem. Please read and get facts. Yes, you're getting some information from the users, but make sure that you read and you get some facts about the problem, okay? Then prototyping, it's trying to form shape. You're developing, you have the concept is coming out somehow, and then in testing, there is more clarity, you're getting focused. So when you test, you get more feedback. So you know now at that stage, you know what you want, and you're just working towards improving on what you already have, okay? Then the design, of course, this process is iterative. There are stages that you'll end up going back to. So it's okay. From maybe testing, you'll get more feedback that will take you back to prototyping. Or from prototyping, you'll get more feedback, like as you prototype, you think there's something that you need to change. But before you go back, make sure that you have tested the stage before you now turn back or before you proceed. And you're sure, at least by the time you get to the last one, there are just a few changes that you're making, okay? We have, this example will come in later. We have an exercise, Dr. Data. Kindly come and take them through the exercise. Thank you so much. Okay, can you all stand up? All right. So we are going to do a very simple group exercise. And this group exercise, we are going to do it in small groups. Okay? All right. How many of you are seated next to somebody they know? If you're sitting next to somebody you know, put up your hand. Okay? All right. So if you're seated next to somebody you know, one of you should step to the middle. Okay, just step to the middle. If you're seated to somebody you know, just one of you should step to the middle. All right. Okay.
Very good. Now, apart from the people in the middle, are you happy that you are not next to somebody you know? I think it's okay here? Okay. So this is going to be the exercise. What I'd like you to do, you're free to disorganize this room the way you want it. Okay? Yes. But I'd like you to form groups of 8. Okay? Just 8. You can turn the tables and make about a group of 8. Let's do it quickly. Okay? Those in the middle will remain in the middle yet. I'm going to deploy you officially. I want to hear chairs moving. If you're seated, I hope your chairs have moved already. Feel free to turn around the chairs, turn around the tables. Are we there, groups of 8? You're 5. Okay, 2 people in the middle from there. Yes, you in a swift shirt. Please come over. And Elizabeth? Join this group. Okay. All right. So those of you in the middle, how many are you? You're 6. Okay, so you're going to make a group around here. Just pull some of these chairs and make your group. This group looks very big. You're only 7. Okay. All right. Are we in our groups now? Okay. So the way this exercise is going to go.
I know the HTV is the only one, the logo is the same.
Okay.
Underscore TV. Yes.
So this exercise needs to be rough and dirty. Okay? Rough, fast, and what? And dirty. So don't overthink it. Okay? The first thing, and this doesn't need to be a perfect problem, but it just needs to be a problem. I'd like you to discuss in your group quickly and arrive at one problem that you would like to work on as a group. Just one problem. You don't need to know the problem completely, but at least one of you should be passionate about the problem. Okay? All right. Now that we're discussing the problem, there are actually 6 questions that I would like you to answer related to the problem. And remember, this is fast and dirty. They don't need to be perfect. Okay? In innovation, we say, in writing, we say we are doing this in writing mode, not in editing mode. When you're in editing mode, your product is supposed to be perfect. But we are doing this in writing mode. So, of the problem you have identified, these are the questions you need to think about. Okay? What is the problem? Who does it affect? How does it affect them? Why does the problem exist? The 5th question is, what are they doing about it now? You see, all the problems that you're thinking about, you're not the first one to identify them. So people have been existing with these what? Problems. So what are they doing about the what? The problem now. And how is what they are doing about it working? You have 20 minutes. Yes, please. So this exercise is going to take a total of 20 minutes. After 20 minutes, you will be given an opportunity to present your work.
What are they doing about it? What are they currently
What is one pound?
Like the way you have learned, you save now. Save.
No, I'm still What's talking? Talking. No, the one you, that one is the same. Let's do one picture.
Take for free. When you take the We just have to copy the environment we just mix them with water and save them
Okay. So we will be presenting in around 8 minutes. So as you utilize these 8 minutes, you need to think about how you're going to present your work.
their cool events because they're not here. The cool event guides will tell us if they are coming straight from. Yeah? The time is good. Drink what your name is. James Stewart. There's Jameson. Nasoma course hiyo. How was it better? It was called development studies. All those stupid courses you're doing, you are doing them as a course university. The thing is, they were causing that back out, people cried. They had to put the name science. Do you have another photo of, wait, John? No, this one. No, this one. Steven. Do you have another photo of him?
The nice big.
No. What is that for global health? Global health. Mary, just a minute. What's your Twitter handle? That's Brina. That's Brina. Let's take a
I like the intensity of the discussion. 4 minutes to go. So as we think about the presentation, each group will be allotted 3 minutes to be able to present their answers to the question, to the 6 questions.
Why did you take me here?
Everybody has to know. The one who is affected, the family that died. But if I die,
Stephen said something. Let the mentors, when we're just talking. No, because mentoring the panel. He said something. Let the panelists Ask Sankara.
All right. So thank you so much for participating in that exercise. So now, these are the rules of the presentation. We are going to have a timer, and Mary is going to time for us. Each of your groups is going to have 3 minutes to present. And the format of the presentation is that you will come to the front, okay? If you have things written on different papers, okay? So if there are 3 papers, please choose 3 people to hold it up, and then you will choose one presenter to go through your what? Your work. Is that clear? All right. 3 minutes. So when your 3 minutes are over, we will clap for you, And when you hear us clapping, it means that it's time up. Okay? All right. So when you hear me and Mary start clapping, please all join in the clap. And let the clapping be so loud that they can't continue to talk. Okay? All right. So the selection is going to be very random, so be prepared to be selected anytime. And the first group to present is this one. Come on. Make it fast and make it fun.
On what? Is it the doctor who has given that one?
The entire group comes. It's a group effort.
Let me consult. What does she say she has? She has an infection? No, please. That is strong medicine on a child. We don't even know what we are taking. That means it is used for infection samples and within pregnant women or people who are testing their period. Yes. Okay. But what is she treating her for? You don't give her anything. Let me pick her tomorrow.
Okay, so please listen to them. You'll realize that there is something to be learned from every single one of these presentations. So even if you have not finished, don't worry. I know your discussion points are in the head. Okay? All right.
So, the problem we identified was poor emergency response when health complications arise. Who does it affect? We discussed that it affects people in rural areas, people in crisis, those who are chronically diseased and they have complications that arise out of the blue, pregnant mothers, especially in hard-to-reach areas, then patients in critical conditions. Then number 3 was how does it affect them? In extreme cases, they die. In other cases, they develop even many more complications for something that could have been treated had it been handled there and then. Then other times, they even transmit these diseases to their neighbors. And when emergency response does not happen and they die or develop even more complications, they are left with lifelong trauma. And in other times, they are stigmatized by their communities. Number 4 was why does the problem exist? The problem exists, lack of emergency response exists because there is a low patient to, there is a low patient to medical. We don't have the numbers, but we all know the ratio is so bad. 1 to 5. Yes, we are informed it's 1 to 5. 1 medical worker to 5 patients. That's a ridiculous ratio. Then lack of policy enforcement and also poor policy, starting from the national level to the municipalities and the local governments. Then inefficiency of the services, reach hospitals and there is no medicine, or because of the longer queues, they're not worked on. Number 5, what are they doing about it? Government is partnering with NGOs, empowering VHTs, patient referrals, the toll-free numbers, and then the digitization of communities and community outreaches. Number 6, how is what they're doing about it working? There has been small deliberate efforts to increase the living standards of people, especially with medical cases. Thank you so much.
All right. So I didn't hear your response to number 6. How is what they are doing about it working?
As we can see.
Okay, so it's time up. All right, so thank you so much. So think about number 6. Don't forget about number 6. People are always, because the problem has existed, oftentimes there is some effort that has gone into what? Into trying to solve it. So you need to identify those efforts and evaluate how those efforts are working. All right, so group number 2 is at the corner right there. Please come up.
Well, thank you. Our problem is lack of antenatal knowledge, especially to the mothers in the rural areas. So, question 2 is like, who does it affect? This one affects mostly pregnant mothers who stay far away from health centers, and also illiterate mothers, and also those that do not have knowledge about antenatal health care. So it also affects the family members in case of death, because if you don't have knowledge about antenatal health, which we are going to discuss, like the effects, we are going to discuss in the third question. So here are the effects. It can lead to death of mothers. Death of mothers. In case you don't have knowledge about the antenatal health, so you will not be able to know what's going on with you. So there is birth complications. There is also complications to the new baby. For example, deformation. The baby may be deformed because this mother didn't go to the health centers for antenatal health. So there is also marital issues. What I would say, misunderstanding between the mother and maybe the father of the baby, because there will be some kind of unfaithfulness between them. Question 4, it's why does the problem exist? It exists because of lack of proper education, also ignorance about antenatal care, poor communication, I would say misinformation, cultural and social beliefs. For example, some mothers leave health centers, they go to their traditional means. Poor health facilities, and lack of health facilities or distant health facilities. The next part is number 5. What are they doing about it? Government has provided UPE and USE in that it helps in educating the children. For example, the children will be able to reach out to these mothers in the villages. There is sensitization through media, organizing health camps, regular antenatal checks and visits. Also, the antenatal check or visit are doing about it working, like how it works. Now the UPE and the USE, it helps in giving people the ability to interpret knowledge, especially antenatal knowledge, or increases awareness about antenatal health. It brings facilities and services closer to the mothers. For example, the health camps we are talking about. Then lastly, it brings a sense of belonging, for example, to the mothers. Those are the points. Thank you.
Okay. You said that the problem you were thinking about is poor antenatal care knowledge.
Yes.
And this problem affects the mothers who are far from the health facility.
Yes.
Okay. And Why the problem exists is because you said they are far from the health facility, they lack proper education. Now, when it comes to what are they doing about it, yes, I realized that you left the mothers and you started talking about the government, what the government is doing about it. But I thought your problem affects the mothers, and you needed to weigh in also on what the mothers are doing about it. What are your thoughts about that?
Yeah, well, the mother also, as we talked here, we try to generalize it in that the government gives the UP and the USE so that people will learn. For example, the students will learn, and then we reach out to the mothers, we give them knowledge.
Okay.
About antenatal health care.
So the government is trying to tackle the problem through you by educating you so that you reach the mothers.
Yeah, that's
and you educate the mothers. Okay? All right. So thank you so much. Please think about what the mothers are doing for that the problem as well. Okay? Thank you. So can I have this group? We had two groups at the back. Yes, please. Yes.
Which one? Where I forgot?
3, 2, 1. Good afternoon, everyone. I'm Clifton Irahuka, and I'm representing the group of the wise. Our problem was inadequate home-based care. Whom does it affect? We identified 5 categories. The first one is the elderly. Number 2, the vulnerable people, like those who are mentally ill, those people living with disabilities. Number 3, mothers who need domiciliary care, those who have delivered within the first 7 days. And the chronically ill, like those with cancer, HIV, and lastly, the general health care system. Question number 3 was asking, okay, how does it affect them? So 1, we saw that there is high risk for self-medication. 2, there is also high risk for late recognition of complications, and as well impaired quality of life and care. Number 4, question was asking, why does the problem actually exist? We noticed that there is no policy and infrastructure to implement home-based care in Uganda if we zero our population to here. Number 2, because of no policy, there is no budget allocation for home-based care. We had quite a number of other ways how this problem affects the people, but because of time we preferred these. Then number 5, what are they doing about it? We noticed that there has been encouragement for innovation and specialization in certain healthcare services. Then lastly, how is what they are doing about it working? Some institutions have taken up the call to train health workers into specialized courses. Mbarara University here is offering critical care nursing, which can as well be taken to the homes. Thank you.
Okay, great. Does anybody have a question for them? All right, I have a question for you. So, how is what they are doing about it working? And you said critical care nursing. And I thought critical care nursing is really hospital care, which tend to be quite different from home-based care. How are you thinking through it?
That was a slip of tongue. What they are doing about it working, actually, individual families are working towards making sure that their loved ones get quality care, either by individually employing people and getting support. They buy medication from pharmacies and take home, for example, oxygen. And they rely on the information given by healthcare workers to any individual member of family. Thank you.
All right. Okay? Okay, thank you so much. Please clap for me. All right. So, Dr. Grace, I like your connecting. Who does it affect? It affects the elderly, the debilitated, and their families. And what are they doing about it? Is what those people are doing about it, their families. Okay? The people who are affected, what are they actually doing about it? Okay? All right. Thank you so much. Okay? Which other group is ready? Yes, the middle group, please.
Yes, please. I'm called Rukwata Godfrey, a student at MAST, and these are my fellow team members. And problem, they are saying our problem is limited access to mental health services in Uganda. That's our problem. Who does it affect? The adolescents. How does it affect them? Dropping out of schools, they do isolate themselves, poor performance in class, sometimes they become violent and also involve themselves in strikes. Why does it exist? It exists because there is limited awareness, there is few mental health workers to offer the services, lack of insights, and also stigmatization. That's why it does exist. Then, what have they done about it or about the problem? They have used social media to air out their problem. They go for social events, they go drinking and also use of drugs, and also they use some different apps. How is what they are doing working? It is two-way-sided. It has gotten short-term reliefs and also long-term effects. For the meantime, they become happy, they become relieved, but in the long run, they still don't get out the solution. So it's two-way-sided. Thank you.
Very good. So mental health problems are affecting adolescents only?
Not really. We chose the most affected.
The most affected?
Yes.
Okay.
Bearing in mind that the biggest population in Uganda is in that age bracket of the youth.
Okay. So, all right. So the catchword here I've gotten from you is that you chose the most affected. And choosing the most affected, in my opinion, limits your what? Your scope of reach. And so if you are a businesswoman or a businessman, if there are hungry people and you say the hungry people are refugees, and yet there are also citizens who are hungry, then You are what? Your client pool reduces.
You start small and grow big.
All right. Okay, so can I have this group?
For that group, you have cheated. Ekate tuli wano Brad. Tuli eri mu kinafu. Tuli eri ku faculty wabwe. Ndowooza tuli era wano. Totawa. Encha. Kumala kawumbe.
Yes, good afternoon. Yes, this is our group. And our problem, the question one was, what is the problem? Yeah, so the problem is patients failing to access doctors and nurses timely. Who is affected? Patients in peri-urban and rural settings. Then how are they affected? The patients are affected in that they get late referrals, they miss diagnosis, there is segregation. At a certain point, maybe a person may be having malaria, and then when the person is still waiting, or a client is still waiting, maybe we get the person who has got an accident. Then they will look at that one who has an accident as if it is emergency. They will treat it as an emergency. Get malaria, 96% of people who get malaria die from statistics. Yeah, then is a spread of communicable diseases. A patient goes to a health facility once they try. By the time, because the doctors are having the bigger numbers, once they get that opportunity to reach there, they take a lot of time there. In that way, they end up, you go with your malaria, you come back with flu, and they're like, why it exists? One, we have understaffing of health facilities. We have insufficient diagnostic tools at the health facilities. Also, patients traveling longer distances to reach the health facilities. I think from the previous people, from panel 2, they informed us that about 70% of the Ugandans stay within more than 5 kilometers. Yeah. Also, we have few health facilities. Then, what is being done about it? Because of lack of accessibility to doctors and nurses timely, people or patients are doing self-medication. People are seeking for spiritual healing. Then also there is seeking for herbal medicine. Then the last question was, what is being done working? So people now no longer go to health centers to seek medical personnel. They run to drug shops near them without prescription and they take up the medicine. The drugs without prescription. Also, we have illnesses escalating to worse conditions because they lack accessibility to nurses and doctors. Thank you so much.
So thank you.
Any question for them? So, how is what they are doing about it working? You told us what they are doing about it, but how is that working for them?
It is actually affecting patients because we have illnesses escalating.
Okay. All right. So, thank you so much. Your team will be next. Okay, please come over. After Peter's team, we will have Brenda's team. So be ready.
You don't present in the
What's your idea?
How are we supposed to get traditional birth attendants come for a hackathon?
Hello everyone, my name is Ernest, I'm a student at MAS, and our team is going to be presenting about antimicrobial resistance. That's the problem we identified, and we discovered or observed that it affects everybody, all of us in the general population, but especially the people who are chronically ill, people who are battling chronic infectious diseases, who have to depend on antimicrobial drugs for their well-being. The other problem was, how does it affect us? Now, when the organisms that cause us disease become resistant to the drugs we have, the cost of care actually increases because we have to opt for more expensive drugs, which most people cannot afford. And this really affects the well-being of all our patients and all of us who are going to suffer from infections caused by these resistant organisms in future. Then also the burden of disease is increased, that is the morbidity and mortality caused by the organisms that are resistant to drugs. Why is this problem affecting us all? Number one is limited knowledge about the right use of antimicrobial drugs and antimicrobial resistance in the general population, because not so many people know about the danger of the way they use drugs and what can come out. Number two is easy and unregulated access to drugs by the authorities. And then the other reason is high cost of drugs, whereby most people cannot afford a full dosage of the drugs prescribed to them, and they have nobody to monitor how they buy the drugs or to support them to afford the full dose. What is being done by the people who are affected? Number one that we observed is Mbarara stewardship by the few who are informed, to inform the rest in their circles. For example, the Mbarara clubs in our universities. I've seen two in southwestern Uganda at MAS and KIU. And then number two that we've observed is closing of unlicensed drug shops by the government. And this is helping people to reduce access to drugs. How is this working? Stewardship is increasing awareness among us, the medics, such that we can inform our patients better and improve on the way we use antimicrobial drugs, and hence reduce antimicrobial resistance and upcoming pandemic. Thank you.
Thank you so much. Okay. Have any questions from them?
Thank you very much. I like the problem, but it looks like there is a solution that is working. So I'm wondering.
So I thought I had the okay, just respond to that.
I stopped hearing that. I like the problem.
Because it looks like the solution that you stated is already working. There is awareness, and so I'm not sure what the problem. Okay, what needs to be done now that the clubs are working and there is awareness?
We think we can do better, and given more time, we can discuss better ways. For example, increasing access to doctors who prescribe these drugs, because people take drugs when they are unprescribed because they can access drugs more easily than they can access the doctors who are supposed to prescribe them. So training more doctors and...
Okay, thank you so much. Okay, so as Brenda's team goes up, you can be coming down.
Thank you so much.
All right. So as you think about question number 6, how is what they are doing about it working? And I think this group gives a very good insight into it. Remember, there are only 2 multi-drug resistant clubs in southwestern Uganda. And if you think about it, how much impact than 2 clubs in 2 universities have in the villages, right? Okay.
Thank you. My name is Emily Musimenta, a student at MAST. So our problem is Ebola outbreak, and who does it affect? We categorize them into 3 groups. We have the health workers, we have the community, and then we have the government. How does it affect them? For example, the health workers, we said there is work overload. Then for the community, we said people are becoming sick, and thus it also leads to death. And for the government, we said there is high cost expenditure. Then why does the problem exist? For example, for the government, we can say that the problem exists because there is poor planning. And for the health workers, we have, for example, inadequate screening. And then we also talked about limited research on this Ebola disease. And then we also talked about inadequate clinical suspicion. What are they doing about it? We said for the health workers, they are providing PPEs, that is personal protective equipment. Then for the patients, there is isolation, and there is also treatment. Then for the community, we said there is sensitization. Then the other 6th part, how is what they are doing about it working? We said on a certain extent it is working because there is evidence that the disease is not spreading widely to other districts. Yeah, that's it for us.
Okay. Thank you so much. A big round of applause to them. All right. So as you come down, Davis's group goes up.
So it's a good evening, I guess. Good evening to you all. Yeah, our group identified a problem, and this is to do with maternal hypothermia. We realized that 23% of the cases to do with women who are undergoing cesarean delivery experience maternal hypothermia, and this condition is actually affecting them in a way that it causes discomfort and shivering and other medical complications like surgical site infections, prolonged wound healing, and it's great. Hypothermia is a drop in the normal body temperature. The core body temperature is about 36 degrees Celsius, and a drop in this temperature is what is called hypothermia. So women undergoing cesarean delivery are being affected by this problem that is causing discomfort and also shivering. So how does it affect them? Yeah, it's what I've talked about. Why does the problem exist? Usually when they're carrying out these surgeries, they induce drugs into the mothers or any other patients so that they can do like a spinal anesthesia. And it affects the thermoregulation of the body. In turn, it causes what we call maternal hypothermia. What are they doing about it? Currently, hospitals are actually using kettles to just boil water and boil IV fluids that are injected into the patients to keep their temperature to normal. Other developed countries are using warming blankets, warming mattresses, which are quite expensive actually for our setting. Oh yeah, for some of the solutions that are currently there, they're working really well, but not to the expected standard. For example, the warming blankets, they can keep the temperature of the lady to about 36 or 35.9, which is not really effective. We want a temperature that will be standard. to be regulated. Thank you.
Okay. Thank you so much. So I think we have how many more teams? One more group, right? Okay. All right, so big round of applause.
As they said, the last speaker is the best speaker. We have taken this one. Good evening, everyone. When you're a doctor and you reach the health facility and you find 100 patients, how do you know that? How do you know which patient to start with? Yeah, this is a challenge, and this is what we have come to. The problem is there is a failure to know the number of patients in the waiting for services to the doctor and their conditions. Who does it affect? Of course, the patients and the doctors. The patients, how does it affect them? They may, the critically ill patients may die immediately. Take it in a case of a heart attack compared to flu. Why does the problem exist? Most of the health centers have an overwhelming number of patients.
Okay, the instruction was that we do through, but let me continue. What are they doing about it? Private facilities see patients mostly on appointments, but for public facilities, you get fast come, fast serve. And how is what they are doing about it working? In private hospitals, it saves time, it also reduces waiting time and improves on patient satisfaction. In the public facilities, yes, there is some coding in place. If the patient is ill, your form has red if very ill, and red means you go in fast. Green or yellow means you wait a bit. Blue means you can even wait longer, but this is not even working in every hospital and in every unit. Thank you.
All right, so thank you so much. Let's give them a big round of applause. Okay. So what we have, you can come back. Nuriat had told us that the first thing in design thinking is empathy. And empathy practically means you're trying to put yourself in the shoes of the person what? Affected. Okay? And so if you look carefully about all these 6 questions have nothing to do with what you would like to propose as a what? As a solution. But all these 6 questions is really about the people who are what? Affected. And so as we started our journey this morning, we started talking about problems. And now I'd like us to transition as we identify this problem. Let's put on the shoes of what? Empathy. And try to understand the problem through the eyes of the people what? Affected. And it's from understanding the problem through the eyes of the people affected that we are more likely to understand question number 6. And if we understand question number 6 properly, and we answer it from the heart, we are more likely to be able to say, okay, this is what they are doing about it. This is how it's working. And if it's not working adequately, why is it not working adequately? And what is it that we need to do to make it either work better or radically change and try something totally different? So thank you so much.
Thank you so much, Dr. Data. Can we clap for ourselves? I can see we have started forming teams, but of course these are not the teams you're going to work with tomorrow. I'm thinking it's up to you. So maybe tomorrow you'll have new challenges that you'll present, and then you'll form teams around your challenges. So this is good, and this is what it means when it comes to innovations. Understand the challenge first before you can actually run to coming up with a solution, because you might end up developing something that will not survive in the market because it did not take time to understand the person you are developing this for. I just wanted to quickly show us an example of one of the innovations that we developed through this process. Who has heard about Mobicare? Anyone who knows about Mobicare? Yes, Dr. Grace? Where is the second microphone? Okay. Yeah, just briefly.
Here is an innovation where a patient make appointment with the doctor and goes to see the doctor at the exact time that is provided. Thank you.
Okay. Now, this is the story of Mobicare. It's one of the innovations that we developed. I lead that team. We started this idea out of my personal experience, where I was pregnant and I was trying to seek, health care. I went to a hospital, and when I got there, I was examined, and they realized that I needed to be seen by a gynecologist. However, on that day, the gynecologist had not worked. So I was referred to another facility, but it all went on until my first gynecologist proposed that I can be seen the next day. I said, okay, let me be patient. But by the time, of course, the pain was intensifying. By the time we got to the next day, it was late. And in my head, I thought, okay, I was thinking, how many people go through this to get a specialist at the time that they need them? First of all, we have a few specialists. If you need a pediatrician in Mbarara, there are few. Okay, there may be many, but they are shared. You find one pediatrician works in other health facilities. They work in a government health facility, but they also work in other health facilities. So it's difficult for me as a patient or a mother to know where to find them at the time when I need them. So we don't have access to their schedules. So you will go to a hospital, it has, they will put a list of services they offer. They have pediatricians, they have gynecology services, they have dental services, but you as a patient, you don't know when these doctors are there when you need them. So I said, I think I'm not the only person facing this problem. There are so many others. Of course, I had faced it before, not about pregnancy, but about maybe you need a pediatrician to see your child. But if sometimes we rely on phone calls, I know Dr. So I can call him and then I request him. But how about someone who doesn't know any doctor? You will get to this facility and they tell you, no, you come back in the evening, or they only work on Wednesdays. So you go back, or you have to look for another health facility. So I put myself in the shoes of any other person who is faced by the same problem. But remember, we are looking at two parties in this, the doctors and the patients or the caretakers. So I put together a team because I knew I could not do this single-handedly as an individual. I put together a team of, young people. We started working. I put them together. I said, there is this problem. Can we try to understand how big the problem is? We used some of these questions. We developed a simple tool with, more of these questions. There are other questions that we included to help us understand what the problem is exactly and how it is being managed. We went to Mbarara Regional Referral Hospital. We talked to heads of departments who allowed us to engage with some of their doctors. I remember we went to the gynecology department. We engaged them and, asked them a few questions. We went to the pediatric department, but we were trying to understand the problem from their side. They gave us very good, feedback. They said, it's a problem. We also don't know what to do. And with that feedback, of course, we also engaged end users. Any person can be a patient, any person can have a patient. We asked them how they are doing how easy is it for them to access a specialist, and more other questions that I can't go into details. And they gave us, good answers. So we came back. We said, okay, now we are going to start figuring out how we are going to do this. So with my team, we looked at the questions. We tried to do a simple analysis. We said, okay, this is where the need is. So we identified where the need was. It was appointment scheduling. There was no system that would allow patients, especially here in Uganda, to have access to doctors' schedules at that time. And so, Dr. so-and-so works here on this day, then they work here. But you don't know when, they know the doctors. But also the doctors, it was so difficult for them to manage their patients' appointments. They were basing on calls. If I work at Divine Mercy and maybe Doctors Plaza and Homely, when there is a patient that needs me to see them, if I'm a gynecologist, they call, no, Dr. So-and-so, there is this patient. Can you please come and see them? You get into your car, you drive, get there, see the patient. You don't know how long it is going to take. They accuse that you have left at this health facility, but you have to attend to them because it's an emergency. Sometimes it's an emergency. But how about if we organize our schedules and okay, on Thursday, the appointments that came through, so on Thursday, I'm going to see patients so and so and so at this health facility. Because they will ask, even if, this may not work for emergency cases, if I know I have my schedule organized, I don't have to run from health facility to health facility, looking, attending to these patients that are not on appointment. In other countries, there are countries where you cannot just walk into a health facility to be seen unless it's an emergency case. But here, sometimes it's different. And there are so many challenges that comes with that. So we engaged them, we got good feedback, we developed our first version, we took it back to them and asked them, what do you think about this? It was just simple. You see this, I think that was like the second version. So we'd meet as a team and look at what we have developed. We had several meetings to look at what we have developed, test to see whether it actually works, and we decide whether we want to take it and test it before we can finally deploy it. So we engaged end users. We even got ethical approvals to do what we call a feasibility and acceptability study, where we took the version we had. It was more improved. It was better than this, I think. The version we had to selected health facilities and not giving it to doctors and patients. We were just showing them and asking them what they think about what we had developed. So we'd show them and then take them through. We give them to try it out, and then we would ask them, what do you think? How do you feel? They say, oh, no, this process is not good. Please change it to this. No, how about if I put this? How about if people can make payments through this so that I know I have confirmed payments, confirmed patients with confirmed payment.
how about like there was good feedback? So from that, we went on and analyzed our data and then picked the feedback that we got and we developed a better version, which we now deployed for use, health facilities. So we put it on Play Store. It's on Google Play Store. We put it on Play Store and then encouraged people to start downloading it. So we went to these selected health facilities and engaged doctors and some patients and requested them to start using it. So they also still gave us good feedback about how the application was appearing. They even said, no, now how about if you get receptionists also manage our accounts on our behalf. If there is an appointment coming in, can the receptionist or my assistant confirm that appointment before? If I'm busy, for example, I'm in the theater, they can confirm it after looking at my schedule. Like, it was really good feedback. Right now, it's still in hospitals. We haven't deployed it in many facilities, but we are still improving. There are changes that they propose where download it. And it's something that we can deploy even like maybe in Kampala, where there is a lot of inconveniences to do with jam, where we think that it will pick up better than maybe here in Mbarara. So like we used design thinking. Every step that we took on what we wanted to add into the application was based on feedback from the end users. As an innovator, I encourage you, if you have an idea, please engage your end users as much as possible. That there's feedback they gave us that we never even thought about. We didn't know about, we didn't think like it would work or best for them. But because it's being developed for them, the patients and the doctors, they knew what they needed better than us, as you know, the owners of the innovation. Thank you so much. This is how it looks like now. So this is the patient side, of course, the interface for the patients. This is the interface for doctors. So the doctor, of course, we worked also, like I mentioned, that you have to work with the different stakeholders. We engaged UMA, Uganda Medical Association. We engaged Uganda Medical and Dental Practitioners Council to make sure that they advised on what we wanted. They advised us on what we could do to make sure that we are working within the guidelines, okay? To make sure that whatever we are developing will be accepted by the user, but also by the doctor, and the policy issues to do with policies. So we engaged them, they guided us, and they gave us very good feedback and advice. So they said, how do we make sure that we don't get people register as doctors when they are not doctors? They said, no, you can have people's licenses. So before we verify you have to put your license number, and then before it is accepted, you're accepted to proceed to add the hospitals where you work and your schedules, the schedules, you have to be verified. You have to be verified before you can continue. So that's how it is, and that's how I think all innovations should be worked on, like using the design thinking process. You engage the end users and make sure that what you're developing will be accepted and will survive in the market. So I wish you all the best. I don't know if you have any questions. Yes, please.
Okay, thank you for the innovation about Mobicare. But as you know, here in Uganda, much as we are health workers and we are meant to help people, we need some money. So under this Mobicare, how does the health worker get paid? Is there like a linkage to mobile money that when you finish seeing a patient, then he sends money, or can attach like a Visa card information and then the patient pays direct to you?
Okay. Like I said, we engaged the end users and the stakeholders. One of the stakeholders we engaged were the hospital, the owners, the directors and administrators of the private hospitals, because MobiCare is meant to work in private health facilities. You will not go in a government health facility and say, no, I need to be seen or make an appointment, like in Uganda, practically. So we said we are going to work with private health facilities. And when we proposed that, we had even already developed it. It was into MobiCare. It was developed and it was working. But anyway, there was some advice that were given by some hospital directors and administrators to do with if someone pays and then what if the doctor does not appear? What do I do? So right now we are working out a way of, so we incorporated cash payment as well. So you can pay by cash, but most hospitals prefer the cash. You come and pay from the counter, but you make an appointment. Though we are still doing more consultation about that. It's been a challenge. The doctors wanted that and we effected it, but the hospitals wanted something else. They needed people to come and pay. Because these doctors, you cannot see, so how MobiCare works, you can't see a patient outside the hospital. This patient within the hospital and they should come to you. But the good thing is that most doctors are paid out of their consultation fees. So the number of patients you get, you get more money because they are seen by you and I think you sign. So at the end of the month, you know how many patients you have seen and you can claim your money from the hospital. These are the number of patients that I have seen in a month. The time, Dr. Data is saying time. Okay, just 2 and then we close. Is it okay? You and then you, then we can close.
Thank you so much for that presentation. So mine is about the IP protection bit. So for most of the projects that we've come up with, the innovations that we've made, we usually do protection for it so that it's not like duplicated and what. So since this is also one of the innovations that you've come up with, I'm wondering, is the protection also important for it? Or
it's protected already. We have a copyright. Yeah, it's protected. Thank you. The last one, then we can.
Thank you, Nuriat, and very sorry for that experience. But may God strengthen you. Okay, it's difficult, especially when you're an innovator in that space where you lose innocent children. So I can reason with you, and yeah. But what's my question? The question is, when it comes to data protection, are you just simply making appointments, or there's a level where you need some data from the patients or doctors that is sensitive, and how are you protecting that data online? Because we have cyber issues. So I'm interested to know what level of protection are you having your application set?
Yeah, it's been a question, but it's only accessed, it's on our server. So there is nobody else who can access it. And the patient cannot see what is on. So you see we have 2 different photos, the patient and doctor's side. So they are all protected, of course, yeah. Thank you so much, Dr. Data. I think, thank you so much for listening. I hope you have learned a lot that you can apply tomorrow and Saturday and all through your innovation life. Thank you so much.
Thank you so much, Nuriat. Before we leave this place, maybe to prepare for the cocktail, there are just a few things I want to state or share with you. For this event, we are having a hashtag, and the hashtag is Healthcare Hack 2022. So you can check out for the Camtech Uganda Twitter handle. You can check for Must and other platforms, and you look out for the information and you retweet. You quote with the hashtag so that we can amplify this information to many other people who are not lucky enough to make it to this event. There are so many people who applied who wanted to be part of this event, but the circumstances could only allow a few of us to make it here physically. So let's amplify the information. Using technology. They've been here since morning to ensure that they do a live stream of this event for other people who are out there to get until Sunday. So they are doing a great job. Lastly, I want to thank each one of you who has been able to come for this summit. Some of you traveled long distances to get here. There was money and of course sacrificing so many things so that you come here and you network and you get to learn a thing or two that can make our country better. So the urge is that we should make use of our time here so that by end of Sunday we have something that can be able to change the status of our healthcare. I thank you so much, and let's meet at the cocktail 6. Thank you. Just missed out something. The venue of the cocktail, we are still having our cocktail from this hotel, but the venue is at the lower end of this facility. So I don't know whether some of you are going to leave and then you come back, but looks like we are getting closer to time for the cocktail. So yes, starting at 6.
Kesho tunaenda kesho. Kesho unajua kesho. Angalia vizuri hii ni date na gani? Kati ya sio jamaa. Sijamuona kule. This is Mama, na cocktail gonna do Sebo, twabagoba nga twagala gwe bwoba okola. It's not good. It's not good. So for you, when you want to go back antibiotic take like another mwingi. You should be. Waikewa dakika 3 walikuwa kwa. Antibiotics, if you want to die in 1